You're
So,
muted, Yogita.
yes,
Yes.
yes, yes, sir. So, sir, is 3, 2, 1. Over to you, sir. We are live to audience the
Yes.
platform.
Good morning. We are again here on second Sunday of the July month. From FOGSI ICOG PG Clinic, we welcome you all. I am Ashok Kumar along with Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, my coordinator for this program. Welcomes you all. And I thanks FOGSI President Dr. Bhaskar Pal, Dr. Sheila Mane, Chairperson ICOG, and other office bearer of ICOG for their valuable support and coordination and granting us this opportunity to continue with this series of ICOG PG Clinic for last 4 years. Today, we have eminent faculty from different parts of the country. And as we always start with doll and dummy, we will be talking about occipito-posterior position. And Dr. Nikhil Shetty from Mangalore will be deliberating on this session. Then we have a case discussion by students of ESI Medical College Hospital, Chennai. Dr. Divya Shankar and Dhanushya will be presenting, and Dr. Vijaya, HOD from ESI Medical College, Chennai, has coordinated their presentation. And we have faculty, Dr. Meeta Gupta, Professor and Head of AIMS Vijaypur, Jammu, Dr. Indrani Roy, Senior Consultant from Meghalaya, very far off Shillong, Dr. Sangam Jha from AIMS Patna, and Dr. Niharika Alu from Visakhapatnam, and along with them, Dr. Ashish Mukhopadhyay will be moderating. Then we will be having on the theme of Master the Technique, Dr. Anupma Bahadur from AIMS Rishikesh will be talking about myomectomy across all eras, comparison of different types of hysterectomy, myomectomy, different approaches. And then in the end, we will have quiz on leiomyoma by our FOGSI quiz committee chairperson, Dr. Archana Kumari. So today we will be having a very wonderful and informative program. And before we start, I request Dr. Sheila Mane, our chairperson, to say a few words.
Yeah, good morning, all. And it's very nice to see everybody assembled again on the second Sunday of this month. And I thank Dr. Ashok Kumar, Dr. Ashish, and Dr. Hafizur for conducting this program very efficiently, even during my tenure. So I welcome you all, Dr. Indrani, Dr. Mita, Dr. Niharika, and Dr. Vijaya, everybody, as well as I'm happy to see my governing council members, Dr. Uma Pandey has also joined, and Divya and Anusha, good luck to you. And today's topic is concentrated on leiomyoma. I think after case discussion, there is some demonstration also and discussion on myomectomy as well as the quiz. So I wish good luck to the students, and very happy to have all of you on this academic platform. And I must thank you that all of you are devoting your time on Sunday for this dedicated academic program, which is really important. And the students are so lucky to, I think, get exposure from the faculty, senior professors from all over the country and from all the zones. So hats off to all our coordinators for bringing out such a nice postgraduate program. And thank you once again. Thank you, one and all. Thank you.
So thank you, Dr. Sheila, madam. And under your guidance and support, we are continuing this program. And let me inform all of you that the recording of this program and all previous program is available on our ICOG websites. I request all the students and teachers to review those recordings and just refresh the memories and revise the topic if anytime you need it. So thank you very much. I just thank you all the faculty, all the teachers for sparing their valuable time for this PG clinic program. Now I hand over the mic to Dr. Ashish Mukhopadhyay to say a few words, and then Dr. Hafizur Rahman will continue with the program.
Thank you, Dr. Ashok Kumar. It has been a wonderful experience being associated with this program for the 5th year in a row. And this has been one of the most consistent program of ICOG today. It has stood out because of the support from the students and immense contribution from the faculty members. I'm very grateful to FOGSI and ICOG, especially Dr. Sheila Mane, who has been very, very proactive and very, very supportive about this program. And I liked his word even during my tenure. That means he also expected that it will continue in our year. Of course, madam, this will continue. And I believe that the student support will take it forward. As you have noticed, the format of the program, as Dr. Ashok Kumar has explained to you, is according to NMC norms. And we would like to have more and more, contributions from the eminent teachers and also the students. Their contribution is also important. Now, having been associated with the with this program for the last 5 years, I feel a kind of oneness with this program. I feel that something of my own is happening. So every second Sunday, I am always there in front of my laptop. This has driven me, and even when I am outside my city, my comfort zone, I don't forget to log in before the laptop. And I have come across many faculty members who have enriched my knowledge and my experiences with the students. I'm ever grateful to this program and ever grateful to FOGSI and ICOG chairman Dr. Sheila Mane and FOGSI president, my dear friend Dr. Bhaskar Pal. Thank you very much, all of you.
Yes, sir. Thank you so much, sir. Yes, sir. So, Dr. Ashok sir, Dr. Pratik Tambi is there. So, I would like to say a few words.
I thought he will be delivering a talk in the conference.
He will join later. He is giving the talk. He has put a message.
He's taking a lecture.
So I request you, Dr. Hafiz, to continue with the program and start with the presentation of Dr. Shetty.
Yes, sir. Thank you so much, sir, Ashok sir. And as Ashok sir said, we are thankful to FOGSI president, Dr. Bhaskar Pal sir, and especially Sheila Mane madam, Dr. Ashok Kumar, and Dr. Ashish Mukhopadhyay sir for consistently being associated with this program for 5 years. So we are constantly trying to evolve, and the situations according to the demand of the students, we are trying to include the different topics in the program. So for the first program, that is the session 1, the topic is an occipital posterior position from arrest to advance mechanism, as well as practical tips for the post-graduation students, because this is very important. We have Dr. Nikhil Shetty. Dr. Nikhil Shetty is additional professor at Kasturba Medical College, Mangalore. So without any wasting time, I'd like to request Dr. Nikhil Shetty to take over the session. Over to you, Dr. Nikhil Shetty.
Thank you so much. So good morning, everyone. So good morning, everyone. I'd like to thank ICOG and FOGSI for giving me this opportunity here today to interact and be part of this amazing program, especially Dr. Sheila Mane, Dr. Ashok, Dr. Ashish, and Dr. Hafizur. So without any ado, I will get straight to the topic. This one. Yeah. So today I'm here to talk about a topic which is very, very important. And in terms, since this program is for postgraduates, whenever these postgraduates for an exam point of view, they see these two things, that's the dummy and pelvis, a lot of these postgraduates feel very daunted about it. It's basically, I understand the emotion behind it. So it basically has to do with the session on the dummy and pelvis basically occurs in the afternoon. It's after this grueling session when you have finished your obstetric case, you have finished your gynec case. Either the session went on very well and you've given up and you said, okay, this is the best I can do, or it didn't go so well and you're very nervous about it. And that's when certain mistakes happen in the labor stations. So this labor station is very, very important. It gives a purview for the examiners to understand whether you understand the complexities of labor. See, as we all know, the entire process of labor which occurs cannot be visualized by any of us. So what we do is we interpret the process of labor through the different phases by our examination and our interpretation of these findings. So labor, the dummy and pelvis gives a purview to your examiner to let you know whether you can understand the complexity of this, identify problems and treat them. All right. So today's topic is to do with malpositions. So when you're talking about, I'm stuck.
Your voice is breaking, Dr. Shetty. I think it's
One second, sir. Can you hear me now?
Yeah. Now it's okay.
Yeah, I apologize for that. Okay, so the topic for today is on malpositions. So when the word malposition, the two things that come to everyone's head is difference between malposition and malpresentation. Now, malposition basically is an abnormal position in a vertex presentation. Okay, malpresentation is any presentation that is non-vertex. It is not non-cephalic, it is non-vertex. So basically, even face and brow come under malpresentations. So any abnormal position in a vertex presentation, which is posterior positions, are considered as malpositions. Now, why are they considered as malpositions? Now, these malpositions do not behave like the normal positions of left occipital anterior or left occipital transverse. Here, basically what can happen is there can be a problem in the labor, there can be a problem in the mother as well as the fetus. And because of these issues, they are classified as something called as malpositions. Even though 70 to 80% of them could deliver normally and have a good outcome, there is still 5 to 10% of them that can have a problem. And that is why we classify them as malpositions. In malpositions, basically what I was talking about is the posterior positions. Now, posterior positions can occur either an anterior position, that actually rotated posteriorly, which could occur in labor, or it started off in labor as posterior. Now, when you start off in labor and posterior, the most commonest reasons why it occurs like that is in some problem with the pelvis. Like, for example, if the mother has a pelvis which has android or anthropoid features, wherein the fore pelvis is more narrow and the hind pelvis is more broader, then the bigger part of the presenting part, that is the occipital part, it has a tendency to fix into the posterior segment, and that is why it's more common. So if you look at the posterior segment, that's why occipital posterior could be common if the pelvis is android or anthropoid. Now, in the posterior, it could be left occipital posterior, or it could be right occipital posterior, or it could be direct occipital posterior. These are the three positions that are possible. Of the three, the most commonest is right occipital posterior. Now, right occipital posterior is more common than left occipital posterior because it depends on the diameter that it is aligning into. So in right occipital posterior, the diameter is the right oblique diameter. In the right oblique diameter, the occiput comes into the posterior part of the segment. Now, in the left oblique diameter for left occipital posterior, that would be like this. The problem is there is the sigmoid colon over here. So it has limits that diameter to a certain extent. So one of the reasons why right is more common than left is the presence of sigmoid colon, which is usually distended with feces because of constipation. Second reason is the uterus, as we all know, has a tendency to move towards the right side, what we term as dextrorotation. And since uterus is dextrorotated, the most available diameter is not the transverse, it's actually the oblique, and that preferably is the right oblique diameter. So if the occiput is in the anterior part of the pelvis, it becomes left occipital anterior. If the occiput is in the posterior part of the pelvis, it becomes right occipital posterior. So therefore, in the positions, right occipital posterior is more common, and therefore it is considered as the third occipital posterior, the third fetal position, secondary to left occipital anterior and left occipital transverse. So how common is occipital posterior? If you look at the early stage of labors, or almost 10 to 15%, all the way up to 40 to 50% involvement of actually starting with occipital posterior is noted. But 80 to 90% of them could deliver or rotate anteriorly and deliver vaginally. and only about 5 to 10% are likely to remain as occipito-posterior, what we call as persistent occipito-posterior positions. Now, these are the ones that are likely to cause us trouble. Okay. So now, next question is, can we actually predict or diagnose occipito-posterior early in labor? It can be diagnosed early in labor when a patient presents in labor based on the symptoms and based on the signs that we are able to see. Patients with occipito-posterior are likely to present to the hospital either with labor rupture membranes or early rupture membranes. That is the first clue. Second, the head may not be well applied into the cervix, so engagement is likely delayed in occipito-posterior position. And third, patients generally complain predominantly of backache rather than the pain which comes anteriorly. So those are the clues when a patient presents like that, we're most probably dealing with an occipito-posterior. And when you examine the patient, the certain features that we're likely to get in the examination is, if the patient is in occipito-posterior, since the back is present posteriorly, like this, the anterior concave, which would have actually occurred because of the back being anterior, is absent. So therefore, there is a suprapubic flattening of the head, the lower part of the abdomen. That also gives us a clue. The third and most important thing is the FHR. If the FHR is present towards the flank at the starting of labor, because the FHR is heard through the scapula, therefore, then it gives you a clue that most probably, yes, we are dealing with the occipito-posterior. So these are certain signs and clues. And then finally, when we do a pelvic examination and you find that the sagittal suture is lying on the right oblique and the occiput is present posteriorly, it confirms that it is right occipito-posterior. But early labors doing a PV is very difficult to identify position. So these clues give you an idea whether you're dealing with an occipito-posterior or an occipito-anterior. Now, coming to the mechanism of labor for occipito-posterior. Now, mechanism of labor is defined as a series of events that occur on the presenting part. So whatever we discuss, all the names of the positions are depending on what movements predominantly occur on the presenting part, and that is mechanism of labor, and that we will be defining right now for occipito-posterior position. So you are likely to get this in the labor viva, the table itself, or you can, even if your college is following CBSE, CBME syllabus, then the thing is you're likely to have an OSCE station on it. So every single step is very, very important. And the most important thing is when you start mechanism labor, do not start saying this is right occipito-posterior and go on ahead. Please define the position of this fetus in terms of the pelvis and in terms of the fetus in utero. So positions, the things that we need to define, obviously first is the lie. The lie obviously is longitudinal, and longitudinal lie is which is defined wherein the long axis of the fetus is parallel to that of the maternal spine or a centralized uterus. The second thing we need to define is the presentation. That is right now in context of this is a cephalic presentation, which can be identified by doing a first pelvic grip, and you find that there is a hard ballotable structure present low down, and that suggests that this is cephalic. The third thing that we need to define is the presenting part, and the part for in terms of occipito-posterior will be vertex. So when you do a pelvic examination, you will be able to find out the vertex, and because it's vertex, the denominator will become occiput. So you need to define this, that is longitudinal line, cephalic presentation, vertex as a presenting part. Now, the attitude is very important, especially when it comes to occipito-posterior. The problem with occipito-posterior and the difficulties is because the head is not usually well flexed. It's likely to be kind of deflexed. Based on the degree of deflection, we have various problems that could occur. So therefore, when the head is not well applied, can you hold the pelvis? And when you do a second pelvic grip, over here, you're likely to find that the sinciput and the occiput is likely to be at the same plane, suggesting, yes, that this head is deflexed. And when you do a pelvic examination, you are likely to identify that you might be able to palpate both the occiput and the sinciput simultaneously when you do a vaginal examination. Okay, so we have defined the fetus in utero for this. Now let's define how it will be present in the in terms of the pelvis. So if this is right occipito-posterior, and when you're holding the skull, please postgraduates remember, when you hold the skull that you're fulfilling everything. Do not hold the skull like this. Okay, this changes the lie and the presentation completely. So even if it's just a skull that we're holding, ensure that we're fulfilling the lie, the presentation, the presenting part, as well as the attitude. So if fulfilling all that criteria, this is right occipito-posterior. posterior. All right. Now, the anterior posterior diameter of the fetal skull for an occipito-posterior is the suboccipito-bregmatic if it is fully flexed. It's suboccipito-frontal or occipito-frontal depending on the degree of flexion. Vertex is equal to flexion. So there's 3 diameters, and those 3 diameters are suboccipito-bregmatic, suboccipito-frontal, or occipito-frontal. In occipito-posterior, the degree of flexion is likely to be on the lesser side. It is going to be incomplete flexion. So it's likely to start off with suboccipito-frontal or occipito-frontal. So this anterior posterior diameter is lying in the right oblique diameter of the pelvis. Okay. And the other diameter that is very important in right occipito-posterior is the shoulder. So if this was how it is lying in the right occipital, the shoulder right now is perpendicular to that. It is lying in the left oblique diameter. So therefore, now we have defined this position clearly as the fetus in utero and the diameter that is assigning within the pelvis. All right. So let's go to the steps of mechanism labor. The first step of mechanism labor for anything is engagement. And engagement is defined as when the maximum transverse diameter of the presenting part crosses the pelvic brim. And for right occipito-posterior, the maximum transverse diameter is biparietal diameter. So if the biparietal diameter enters the pelvic brim, we say the head is engaged and the station has reached 0 station. All right. So first step is engagement. The second step is descent. So descent predominantly occurs because of 4 things. The first and foremost thing that really needs to occur is uterine contractions. Uterine contractions basically act on the uterus and divide the uterus into 2 phases. That is the upper segment as well as the lower segment. Upper segment is active, which causes the contraction. The lower segment is passive. Now, the lower segment needs to form because uterus is pyriform shape. It has to become cylindrical. So second thing predominant to occur for descent is formation of the low uterine segment. The third thing is one that causes the maximum descent is the bearing down efforts of the mother, and finally by gravity. So therefore, these things work on descent, and descent is a process that occurs completely throughout labor. All right. So then next step is the most important step in terms of occipito-posterior is flexion. Now, for flexion to occur, whenever the presenting part hits the pelvic floor, there is an elastic recoil from the levator ani muscles. So therefore, there is contraction acting from above. There is elastic recoil occurring from below. One of the theories why flexion occurs is to do with the 2-arm lever theory. So the 2-arm lever theory is that the occiput is the fulcrum. There is one arm from the occiput to, the atlanto-occipital joint is the fulcrum. There's one arm from the atlanto-occipital joint to the occiput, and one arm from the atlanto-occipital joint to the mentum. So whenever an equal amount of force is acting, the more far away from the fulcrum, the less amount of force. So therefore, this head is likely to flex. Now, in occipito-posterior, flexion is usually incomplete, and that is the reason why there are problems. So if it is a well-flexed head that it enters inside here, then this hits the pelvic floor, and then comes the next step, that is internal rotation. Now, internal rotation is the most important step that occurs here. So now in internal rotation to occur, it has to rotate from right occipito-posterior to right occipito-transverse, from right occipito-transverse to right occipito-anterior, from right occipito-anterior to occipito-anterior. So it has to rotate by almost 3/8 of a circle. When you're in your exam, either you decide you're talking in degrees or you're talking in eighths. So since we are very poor in mathematics, I would strongly suggest you stick to eighths. So the rotation is from right occipito-posterior all the way down to occipito-anterior. That's by 3/8 of a circle. And we all know that the neck cannot take any much torsion more than 1/8 of a circle. So therefore, when it entered here, the shoulder was in the left oblique, the anterior posterior diameter was in the right oblique. Yeah, I hope you can see this. So, yeah. So now when the head rotated throughout from right occipito-posterior to right occipito-transverse, from right occipito-transverse to right occipito-anterior to occipito-anterior, the shoulder compensates and comes in the right oblique diameter, covering about 2/8 of a circle, leaving a torsion of 1/8. From here onwards, the steps are exactly the same as that what would have been in the left occipito-anterior. All right. So the next step which occurs is crowning. Now, crowning is a step wherein when the occiput hinges under the pubic symphysis, the presenting part does not recede back on cessation of a contraction. That is when the vulva is maximally distended, and this is the time that we are likely to give an episiotomy. All right. So After this, at the time of the crowning, now there is a change in the fulcrum. The fulcrum, which was present at the atlanto-occipital joint during the flexion part, has now the occiput is hinged under the pubic symphysis. So the fulcrum reaches here. Now we have only one arm. So the next step is delivery of the fetal head by extension. Okay. Now the head is completely free. Nothing is holding it, but it had a torsion of 1/8. So it will untort itself. So it will undergo the process of restitution. Now the shoulders will enter the pelvis in the right oblique diameter. And we know that whenever anything enters in the pelvis right diameter, it will turn to anterior posterior because the way the liver trine pushes whatever is anterior. So therefore, the head will move in a direction, and that is why it's called external rotation. So it was here, it turned in this direction. Finally, the baby's face will point towards the mother's medial surface of the left thigh. And that's when we know the shoulders has become anterior posterior. Therefore, now what happens is the shoulder hinges under the pubic symphysis, and then the left shoulder hinges on the pubic symphysis. The right shoulder slips through the pelvis, and baby will deliver out. This is the most favorable position, that is right occipito-posterior, which underwent a long arc conversion, that is from right occipito-posterior, right occipito-transverse, occipito-anterior, and to direct occipito-anterior, that is by 3/8 of a circle. And this is can occur in 80 to 90% of the pregnancies. Now, the problem comes with right occipito-posterior. It may, depending on the degree of flexion, it may do something differently. For example, if it was here like this, it may turn only about one part of it anteriorly and lie in the transverse diameter. Okay. All right. Sorry. So it lies in the transverse diameter. If it lies in the transverse diameter, it doesn't turn anteriorly. And if it stays there for some time, we start classifying it as an arrest disorder, and that is a deep transverse arrest. For to be classified as a deep transverse arrest, following parameters are most important. One, the head is in the sagittal suture is in the transverse diameter of the pelvis. Two, it is at level of the ischial spines, that is at 0 station. 3, that there is very good uterine activity and it has not descended or changed position for next 1 hour. And that's when we classify this as a deep transverse arrest. Okay, this is another possibility that occurs, wherein it turned only about 1/8 of a circle and got arrested there. That is deep transverse arrest. Other thing it can do, it can remain in 10% position as itself did not move anterior, did not move posterior. That is called persistent right occipito-posterior position. Or sometimes what happens if the head is markedly deflex, then the sinciput hits the pelvic floor first. Hold the pelvis down. So when the sinciput hits the pelvic floor first, it's in the anterior part of the segment. It turns anteriorly. If it turns anteriorly, the occiput turns towards posterior, and this becomes direct occipito-posterior. Now, problem with direct occipito-posterior is that delivery process is quite traumatic for the mother, because the biggest or the widest part of the occiput is coming toward the posterior part of the perineum, that is near the anal sphincter. So OSC, that's obstetric anal sphincter injuries, are likely to occur. But if the pelvis was adequate, or if the pelvis, the mother was a multigravid lady, and the baby size was slightly small, face to pubis delivery is possible. So in the steps of face to pubis delivery, after internal rotation occurred, that means it turned from right occipito-posterior to occipito-posterior. Instead of crowning, what will happen here is the presenting part will descend down. Depending on the degree of flexion, either the nose or the sinciput will hinge under the pubic symphysis. So if this part hinges under the pubic symphysis, now the fulcrum has moved towards the nose. So the first step is not extension, it is flexion. So what comes out first is the brow, the vertex, and finally the occiput comes out first. Then the head tends to extend backwards and deliver by extension. So face to pubis delivery occurs in 2 phases in terms of the fetal head delivery, and that is, first is flexion and second is by extension. Then the shoulders will become anterior posterior, and then finally you will deliver and come out. And that face to pubis delivery is possible if the pelvis is adequate, the mother was a multigravid lady, and if the baby is of an average size, then we are likely to do it. But in a primigravida, a moderate sized baby, if the bigger part of the occiput comes out to the posterior part of the pelvis here, then it is likely to damage the posterior perineum, especially the anal sphincter and the rectum, and rip it apart, and therefore causing obstetric anal sphincter injuries. It can also cause multiple tears in the vagina and also perineal injuries. So therefore, it is not really recommended that we actually do a face to pubis delivery. So in occipito-posterior, in the mechanisms, there are three things that only can occur. The most common is the most favorable one, that is the long arc, that is turning from right occipito-posterior all the way by 3/8 of a circle, shoulder compensating by 2/8, and remaining process as what we had explained. Second possibility is the short arc, that it turns anteriorly only by 1/8 and gets stuck there, and what we defined as deep transverse arrest. Now, deep transverse arrest basically is defined when it is in the transverse diameter at the level of the ischial spine 0 station, did not descend for a period of 1 hour despite very good uterine activity. Then we call it deep transverse arrest. Or it could remain as right occipito-posterior and get arrested there. Or it can turn by 1/8 of a circle posteriorly. That's because the sinciput was in the anterior part, got pushed anteriorly, and therefore the occiput came posteriorly, and therefore it becomes anterior posterior, and that is what we call as direct occipito-posterior. And if delivery has to occur, it occurs by face to pubis delivery. And that face to pubis delivery first is by flexion, and then is by extension. Then there's restitution, and then external rotation, and finally the delivery. This is the mechanism of labor for occipito-posterior. Now, problem with occipito-posterior is not all of them will follow this rule. They can get stuck in various phases. So in terms of arrest disorders for occipito-posterior, it is important to know for occipito-posterior per se, the arrest disorder is predominantly to do with arrest of deep transverse arrest. The remaining is like for anything else, arrest disorders. In the first stage is arrest disorders of cervical dilatation, that based on the partogram, or if you're following the labor care guide, based on that itself. One of the causes for that would be occipito-posterior, or it could be arrest of descent, wherein the cervix is dilated for either 2 hours or 3 hours, depending on the protocol we are following, and delivery does not occur. But for specific occipito-posterior, it's only deep transverse arrest. So question now arises is, do we need to diagnose it early and manage it? So what if we had diagnosed it in the beginning of labor and we found out it is right occipito-posterior? Can we do anything about it? Now, there are a lot of studies that have tried various things, not so fruitful, but things that postgraduates need to know about is, if you diagnose it early in this, please understand that the following problems are likely to occur. Therefore, labor is likely to be a little problematic. One is if she develops early rupture of membranes, the LICA drainage can occur. It can end up in dry labor, and therefore the fetus can get compromised as the labor is likely to be more prolonged. Number one. Second thing likely to occur, the patient complains of a lot of pain. So epidural analgesia is mostly required in these women. And if it can be given, then progressive labor is potential. But even labor analgesia is likely to cause the rotation not occurring. So that is also a small detriment, but various studies have proved that labor analgesia has not really increased the incidence of persistent occipito-posterior. The next thing is that we can also recommend and teach our counsel our patients at the beginning of labor that labor is likely to be a little more prolonged. The chance of cesarean section is a possibility, and we can tell them earlier in labor once we diagnose them. But we cannot do anything much. Now, the thing is, once we reach the later stages of labor, 80 to 90% of them will rotate anteriorly, and we don't have to do anything much. It is for the remaining 5 to 10% that is likely to cause a problem. So one of the things that possibly that have been tried is manual rotation of the head. Now, manual rotation of the head has been tried a lot in Western literature, and that can be actually considered before the arrest has occurred. Now, for manual rotation of head, there are a few things that we need to think about before we consider manual rotation of head. Now, occipito-posterior position might have occurred because there is an abnormality in the pelvis itself. That is, it could be android or an anthropoid type of pelvis. In that situation, the most rate-limiting step is the ischial spines, and the interspinal diameter might be less. If the interspinal diameter is less, then the progressive labor will not occur. So it's not really that futile, not that lucrative to actually do a manual rotation of the head, because unless we're sure about the pelvis. And the problem is our Indian women and the pelvises are much different from the Western women. And Western literature has recommended that we actually do, including ACOG, that manual rotation of the head can be tried. Now, manual rotation of the head is basically what we do is, before the head gets stuck, using our hands, I'm sorry, there's a little bit of CPD with this skull and pelvis. If it entered here, manually we rotate the head before it got arrested using a hand. So one hand goes below the occiput, other hand is on top here, and manually rotate the head before it gets stuck to occipito anterior positions or a more favorable position. Now, if you're doing this, this has to be done either under epidural analgesia or under anesthesia. Should not be tried in an labor room theater, or at least a pudendal block needs to be given. This can be tried, but even if you try this, there's no guarantee that they'll end up in a normal vaginal delivery. So this is one thing that PGs need to know. The other things that PGs need to know is, for theoretical purposes only, is the use of double forces application can be tried, or even using a vacuum. But since the station is a little on the higher side, and we do not apply forceps nowadays, anything which is above +2 station, then using this is very, very unlikely. So therefore, for occipito-posterior, the things that we need to understand very clearly is that occipito-posterior is a malposition. It's considered as a malposition predominantly because that it does not follow the rule. The effect on the mother, fetus, and the labor is there. In labor, the labor is likely to be prolonged. They're likely to be arrest in there. And in the mother, they could develop postpartum hemorrhage. They can have perineal tears, vaginal tears, cervical tears is possible, or even if it's a face-to-pubis delivery, even include OAC, that's obstetric anal sphincter injuries, can occur. The other thing that possibly could occur is in the fetus, patients who have persistent occipito-posterior positions are likely to have poor UBGA scores and may require NICU admissions. So therefore, it is important that we diagnose occipito-posterior, and it is important that we manage them as such. I hope I've covered it completely. If there are any questions or any queries, or you want anything repeated or redone, if someone could tell me, I would do the same.
Yeah.
So transperineal ultrasound, does it help, sir, during labor?
So in labor right now, a lot of research is occurring using ultrasonography. One is to diagnose, I'll talk in terms of occipito-posterior. So we can actually, ACOG also recommends doing an intrapartum ultrasound, that is either transabdominal or transperineal. There are also other parameters when you look in transperineal to identify success of delivery, look at the various angles. That is a different concept altogether. But in terms of occipito-posterior, they have recommended to get a proper diagnosis, because when you're dealing in the second stage of labor, because of the development of the caput succedanum, identifying occipito-posterior is very difficult. And the one thing that helps us diagnose it is by feeling the ear, which is a very, very painful examination. In such situation, we could switch over to ultrasound to confirm the occipito-posterior position, either transabdominal or transperineal.
Yes, sir. Nikhil sir, thank you so much. Dr. Ashish sir is there? Dr. Ashok Kumar sir?
Hafizur, Dr.
Yes,
Nikhil,
for your comments,
yeah,
please. Yes, sir.
very clear. The flow was very good. Okay.
Yes, sir.
And I would like him to say hi to his classmate, Dr. Mahesh, who is currently the president of BSOG.
Hi, Mahesh.
Hi, Nikhil. Good session. Excellent. We were listening to your lecture, and really it was helpful and very nice.
Thank you, Mahesh. Thank you so much.
All the students have benefited. This is a very difficult topic. You made it so easy. And I remember he used to teach us also during MD time. We were classmates.
We used to discuss a lot. Yes, we used to.
So very
Yeah,
nice.
thank you so much, sir. Dr. Nikhil Sethi, I think you have done excellent demonstration, and the students will be really benefited from it. And the session will be in recording in the ICOG website as well as in the YouTube also. It will be available. So thank you so much for your excellent demonstration. I would like to have you in future program for ICOG again. So thank you again so much.
Thank you so much. Thank you for the opportunity. If there's anything, people can just message me and I'll answer the questions. Thank you.
Sure,
I
sir.
think
Good.
Pratik is here. Pratik has joined.
Yes, sir. Dr. Pratik, sir, for your
Good
just
morning,
comment.
everybody.
Yes, sir.
Fantastic FOGSI ICOG PG clinic. As always, hats off to the coordinator, Dr. Apizur, Dr. Ashish Mukhopadhyay, Dr. Ashok Kumar, sir. Excellent job, wonderful teaching. I see all the stalwarts from across the country, Dr. Vijaya, Dr. Indrani, Dr. Nikhil Shetty, and Dr. Anupama. I'm actually a fan of Dr. Anupama Bahadur. So amazing work being done, even on a Sunday. Thank you for sparing your precious time and sharing your valuable knowledge with all the students. I'm sure everybody is being benefited. Thank you so much for having me here. I wish you all the very best. Please continue.
Thank you so much for your encouragement, sir. So without any wasting any time, we'll move on to our second session. That is one which is one of the very consistent session from the very beginning. The session is on case discussion. So this month we have students from ESIC Medical College and Hospital, Chennai. And the students are Dr. Divya Shankar and Dr. Dhanushya NL. And they have been very nicely guided by their professor and head, Madam Dr. Vijaya. So, and we have faculties from all corners of the country. So we have Dr. Ashish Mukhopadhyay, sir will moderate the session for the case discussion. Sir is principal and professor at CSS College of OBGYN at Child Health, Kolkata. Then we have Dr. Mita Gupta. Madam is professor and head at AIIMS Vijaypur, that is in Jammu and Kashmir. We have Dr. Indrani Roy. So welcome, madam. Madam is senior consultant and HOD at Nazrat Hospital, actively involving in postgraduate students, DNV students. We have Dr. Sangam Jha. Madam is professor of OBGYN at AIIMS Patna. And we have and the last but not the least, we have Dr. Niharika Allu. She is senior consultant at Rainbow Hospital, Visakhapatnam. So I'd like to request Dr. Divya and Dr. Dhanushya to share your screen, introduce yourself, and start your presentation. At the same time, I'd like to invite all the faculties, Dr. Ashish, Dr. Mita, Dr. Indrani, Dr. Sangam, and Dr. Niharika, to kindly examine the students for their case. Over to you, all the faculty and students, please.
Thank you, Hafizur. Before we start, yes. I think we have Dr. Pratik Tambe here today. And in the morning, we missed him because he had one lecture. So I would like to invite Dr. Pratik Tambe, the Secretary of ICOG, to share a few words of appreciation or encouragement, whatever he says to us.
Sir has already told, sir.
Okay. Thank you so much. Thank you, Dr. Pratik. Thank you. Okay, so students, are you ready?
Yes, sir.
Okay. And then share screen, one of you, Divya or Dhanusha, one of you might share the screen.
Yes, sir.
Good afternoon. Yes. Dr. Sangam, are you there? Dr. Sangam? Dr. Niharika?
I can see Dr. Niharika Allu, yes.
Yeah.
Niharika is there, Dr. Sangam.
Dr. Hafizur, I'm here.
Yeah, but we are just confirming. Indrani, madam is there, Dr. Mita?
Yes, sir.
Yeah, over to all of you. Thank you so much.
Good afternoon, everyone. I am Dr. Divya and I'm Dr. Dhanushya. We are third year PGs from ESI Medical College, KK Nagar, Chennai. We thank our coordinating faculty, Professor Dr. Vijaya ma'am, our professor at our Department of OBG in ESIC Medical College, KK Nagar. We also thank the FOGSI and ICOG PG Clinic for giving us this opportunity to present. Thank you. Starting with the presentation. Presenting the case of Mrs. XYZ, a 44-year-old female who has studied till 10th standard. She works in a shoe company and she's hailing from Arumbakam in Chennai, which is around 5 kilometers from the hospital. Her socioeconomic status, as per the modified Kuppaswamy classification, she belongs to the upper lower class society. Her chief complaints are she came with the complaints of heavy menstrual bleeding since 1 year and generalized fatigue and breathlessness on exertion since 2 months. Patient was apparently well. One second. Not able to see this. Okay. Yeah. Patient was apparently well 1 year back when she developed heavy menstrual bleeding, requiring a change of 10 pads per day, changing 2 pads at night, lasting for 7 to 8 days in a 30-day cycle duration, with associated dysmenorrhea on day 2 and day 3 of a cycle, which relieved on medication. It was also associated with passage of clots. It interfered with her daily work and her social interactions. She has not kept consistent follow-ups with her doctors or the treatment given in the past 1 year. She also complains of a recent onset generalized fatigue and dyspnea on exertion since 2 months. History of presenting illness. There is no history of intermenstrual bleeding, postcoital bleeding or dyspareunia, no history of foul-smelling discharge per vaginum, no history of loss of weight, appetite, or fever, no history of frequent micturition, incomplete voiding, or dysuria, no history of tenesmus or constipation, no history of cold intolerance, weight gain, and no history of any specific treatment or investigations given by the local physician for the past 1 year complaints. Menstrual history. Her menarche was at 13 years. She attained menarche at 13 years of age. She has regular menstrual cycles since till 1 year back, which were lasting for 3 days in a 28-day cycle. And she changed only 2 pads per day with no passage of clots and no associated dysmenorrhea since menarche. Her last menstrual period was 15th of June, 2026. Marital history, she's been married since 27 years in a non-consanguineous marriage, living with the husband under the same roof. Obstetric history, she is a para 2, live 2, with 2 full-term vaginal deliveries, both girl-child, and who are 21 and 19 years of age currently. No history of any contraceptive usage, no intrauterine device usage, and no history of sterilization done. Past history, there is no history of any medical comorbidities like systemic hypertension, diabetes mellitus, bronchial asthma, tuberculosis, epilepsy, stroke, or cardiovascular disease. No history of any other past gynecological surgeries or other surgeries. Past treatment history for the same complaints. History of 1 pack cell transfusion and 2 doses of parenteral iron were taken at a nearby private hospital in view of similar complaints 6 months back for a hemoglobin of 4.1 grams. Repeat hemoglobin was not taken as the patient did not have follow-up after that. History of drug intake for 5 days to decrease bleeding given by the doctor during the anemia correction, but no records were available during history taking. Family history, there is no history of systemic hypertension, diabetes mellitus, or tuberculosis in the family, no history of similar problems in the family, no history of gynecological malignancies or any other malignancies in the family. Personal history, she consumes a mixed diet with a normal appetite, normal sleep, and normal bowel bladder patterns. There is no history of substance abuse and no history of drug allergies. Dietary history, based on her 24-hour dietary recall, the calories recommended as per her lifestyle, which was a moderately active lifestyle, was around 1,500 kilocalories per day. But the total calories she consumed was 1,559 kilocalories. So there was actually an calorie excess of 59 calories per day being consumed. And the total protein recommended as per her body weight was around 50 grams per day, taking 1 gram per kg per day. But the total protein she had consumed in a 24-hour dietary recall was 54 grams. So she had no calorie or protein deficit as per dietary history. Can we proceed to examination, sir?
Any of the examiners would like to interact on the history part? Or I think I'll go to the examination part and then take up the crossing in the final. Is it okay, all the faculties?
Yes, sir. Yes, sir.
Go ahead, please.
Yes, sir. Moving on to the examination, general examination was done after obtaining informed consent from the patient and asking her to empty the bladder. Patient is well built and nourished. Pallor was present. No pedal edema noted. Her blood pressure was 120/80 of millimeters of mercury. Her pulse rate is 90 beats per minute. Her breast examination was normal. No thyromegaly was noted. Her height was 150 centimeters, weight of 50 kgs. Her total BMI came to 22.2 kilograms per meter square. Systemic examination, cardiovascular system, S1 and S2 heart sounds were heard, no murmurs. Respiratory system, bilateral normal vesicular bed sounds heard, no added sounds. Central nervous system, no focal neurological deficit was noted. Per abdomen examination, on inspection, the abdomen appears normal, umbilicus is central and inverted. Striae albicans were noted, no sinuses, scars, dilated veins, or visible pulsations. All quadrants of the abdomen move equally with respiration. Hernial orifices were intact and free. On palpation, a firm, irregularly enlarged, non-tender mass with smooth margins that is extending from the suprapubic area and occupying the suprapubic and the right iliac area was noted. It corresponds to a 16-week size gravid uterus with a dimension of 16 cross 12 centimeters. Side-to-side mobility was there. Lower border of the mass was not palpable separately. No other organomegaly was noted. Local examination, external genitalia was normal. On perspeculum examination, cervix and vagina appeared healthy. Cervix was appeared pulled up. On bimanual examination, uterus is anteverted, irregularly enlarged to a 16-week size. The mass was felt through the right fornix. Other fornices were free and no fornicial tenderness was noted. Transmitted mobility was noted from the cervix. No groove was felt between the uterus and the mass. So moving into the provisional diagnosis, a case of a 44-year-old para to live to previous 2 normal vaginal deliveries with heavy menstrual bleeding, secondary dysmenorrhea and anemia. Examination shows pallor with an irregularly enlarged non-tender 16-week size mass with smooth margins and side-to-side mobility arising from the uterus that was palpated through the right fornix. A probable case of abnormal uterine bleeding, leiomyoma with anemia.
Okay, so yes, go on the differential diagnosis. If you have a slide on that, yes.
Yes, the differential diagnosis could be, it could be a full bladder, pregnancy, hematometra, adenomyosis, a tubo-ovarian mass, ovarian cyst, pelvic endometriosis leading to a chocolate cyst, a pelvic kidney. These are some of the differential diagnoses of this case.
Okay. I think Divya and Anusha, you have done a reasonably good job. I just wanted to ask you, where is the summary? You haven't put in the summary here. You have been given a provisional diagnosis, but before that, the summary of the case comes. And you must write that in your exam sheet. Okay. Based on that, you will have your presentation in the examination. Okay.
Okay.
Have a summary slide, summary of the case, and then provisional diagnosis. That's okay.
Okay, sir.
Okay.
I would like to invite Dr. Meeta Gupta and Dr. Indrani Roy to cross them on the history part and the general examination part.
Divya and Tanusha, you both have done a great job. But can you come to your differential? Why was full bladder as the first? See, the patient had very similar diagnosis. She had given us anemia of HB going to 4 grams. So why full bladder was the first differential diagnosis?
You can put the presentation on, Divya.
Yes,
Because,
sir.
the examiners may want to see the slides, no?
Yes, sir. Yes, sir. Yes, sir. Is the same?
Make it slideshow.
Yes, sir.
And move on one slide after another slowly. Okay. And show us the differential diagnosis. Yes, this one. Dr.
Yes,
Meeta Gupta wants this. Yes. Yes. The question was why the full bladder was shown as the first differential diagnosis. Did you run out of ideas? Or is just a convention from a textbook? What was the reason, basically?
If we go by symptoms, actually the symptoms, and as you had brought up the past history, that she has already been treated for the same. Ideally, full bladder is not.
Divya, you are a third year. No, Divya, you are a third year PG student. This is not we expect from a third year PG student. Bacha. It is an MBBS.
Undergraduate is expected.
Yes.
Undergraduate is okay.
Yes.
Yeah.
You had given us such a good history where you're giving us that patient had gone up to 4 grams. She had been on and off a treatment, menorrhagia. Neither full bladder, neither pregnancy would be, should have been on top of your list of your differential. This was the only thing where I objected. Otherwise, your history was absolutely great going. I did not object much to any of those things. But this was your differential, see, because whatever is the main diagnosis you're going to tell, that should have been first from there. And you had put in full bladder and pregnancy, and I really could not stop myself from there. Okay?
Yes,
So please take care of this. Then coming to, please tell me.
Go to the first slide.
Huh.
History part is okay to you?
और आगे जाओ बेटा 1 minute.
एक एक करके आओ. First से आओ. Any more detail you want here?
Religion and all.
No, I think that the patient, when she was admitted, and when she was examined. Date of admission, date of examination. Is it missing here? I think you should.
Yes, sir.
Yeah.
Isn't it? So identification of the patient particulars. This is important in your history sheet because the interval between the admission and the examination, what are the evolution of the case that has happened? And remember, all long cases have to be admitted cases. This you should remember for your lifetime, because
Yes, sir.
otherwise a long case cannot happen in an OPD. That's the short.
Yes,
Okay.
yes.
So when she was admitted and when she was examined, I think that's a good information. And apart from that, you can have the registration number or bed number of the patient as identification point of the patient. Okay.
Okay, sir. Okay,
Move
sir.
on to the next slide, please.
Can I also add on, sir?
Yeah, good.
Occupational exposure related to fibro. The recent studies. It's a lot of endocrine disrupting chemicals when they work on the beauty products or canned foods because of the bisphenol and lot of dioxins. That is also evidence says it could be a cause for fibro. Yes, sir. Next.
Okay.
Yes.
So she's 44 years, Mrs.
Yes, sir. Yes, sir. Yes, sir.
Okay. Anything else to add? Or you go ahead, move ahead, please.
Next slide.
Okay, sir. Okay, sir.
Yes, this socioeconomic status, according to the Kupuswamy scale, has given some distinct classifications or divisions. You should write that, and then whether it fits into the upper lower class or lower middle class, etc., that you have to mention. Okay.
Okay, sir.
Okay, sir.
Okay. Next. Yes, as I think the concept of question of full bladder was questioned. Here, there is no complaint about full bladder or frequent detention of urine or something like that, isn't it?
Yes.
So, in a
Yes, sir.
gynecological history in a postgraduate student, I think I'll like to agree with Dr. Meeta Gupta that it should not come as a differential diagnosis. Here is the logic. Remember, whatever you write in your history sheet, that must be, based on a reason, sound reasoning. That why I am putting this, even the not only the differential diagnosis, but also the so many negative histories that we put. We'll come to that later on. That we do not know that whether they're directly associated or not, but we put them. That tendency has to be, this is acceptable in undergraduate examinations, but not in postgraduate examination after having 3 years of rigorous training under Dr. Vijaya.
Sir, I didn't see this slide actually. It was added last night.
Yeah. No, it's okay. It happens. Next slide, please. Go ahead, move ahead.
Yes, sir.
Yes, Indrani, anything to comment here? You would like to comment anything here?
Yes, sir. Here what she has given the history very nicely presented actually. So heavy menstrual bleeding, any history of any like difficulty in micturition or any urinary symptoms, whether is it positive or negative. If she has no, then I think the negative history also has to be written there. And what is the significance of any urinary complaints in such patients? I would like to ask them.
Yeah.
Is there any relationship?
Crossing part will come later on, Indrani.
Okay, sir.
Whether they have included that or not. Yes, this question has a positive bearing because the pressure symptoms, the patient will complain of retention of urine or frequency of urination, etc. But I would like to draw your attention to another event that happens in a woman who is having HMB, heavy menstrual bleeding, that whether this patient needed nighttime changes of pads or not. I think they have mentioned about the number of pads.
They have mentioned that.
They have mentioned, no? Yes.
Yeah, 2 pads at night. Yeah, they have mentioned.
Okay. So that is very disturbing because not only does it disturb the sleep, but it also gives an idea about the heaviness of the bleeding. And it also directly interferes with the daytime activities, her sleep. She's a working woman. So I think that's a very, very important
quality of life.
Quality of life, yes. And that is why that is very, very important. Whenever we talk about the heavy menstrual bleeding, we tend to be subjective. That means we tend to believe whatever the patient says. But there are some corroborating facts or questions we can ask the woman. If she's suffering from them, then it becomes automatically obvious that yes, she's suffering from heavy menstrual bleeding. Like for instance, some of the women may be fastidious about the change of this thing, napkins on small provocation, like a little bit of soaking, and she changes it. But not when then there is nighttime change. That will not happen in nighttime changes. So whenever the nighttime changes are there and she wakes up in the middle of the night, that positively denotes that she's really having suffering from the heavy menstrual bleeding.
Yep.
Having said that, we the gynecologists are often blamed for underestimating the amount of bleeding. So we have to believe this patient having heavy menstrual bleeding based on these findings. Also, there are other evidences. We'll come to that later when we deal with investigations, like a hemoglobin of 4.9% definitely points towards a heavy menstrual levels.
Yes. Going
Yeah, go ahead. Any other faculty, if you have any question, please raise it. Okay, I want to finish it fast. Yes, this is the
Yeah,
negative.
they have mentioned that one. They have
Can you
mentioned.
explain?
Yes.
Yeah.
Yeah,
Can you explain why you have asked these history of intermenstrual bleeding, postcoital? What exactly are you thinking? Like, what are you trying to rule out by taking this negative history?
with respect to intermenstrual bleeding, yes, ma'am.
Yeah.
With respect to intermenstrual bleeding, we were looking at ruling out a possible cervical polyp or a submucosal fibroid, ma'am. With respect to postcoital bleeding, any local pathology also, which is bleeding, again, a cervical polyp or a cervical erosion, which could be bleeding mainly. With respect to dyspareunia, to rule out adenomyosis mainly, ma'am, and even endometriosis, if so, associated. No history of foul-smelling discharge per vaginum was again for a submucosal polyp, which may be extruding outside the cervical canal and exposed to the environment, and hence having foul-smelling discharge, or it could be some form of a cervical lesion again, ma'am, or so cervical lesion. No history of loss of weight, loss of appetite, and fever is mainly
apart from the polyp that you have mentioned correctly, postcoital bleeding is usually associated with another, serious condition in the cervix that you must say.
CA
That's
cervix.
the first symptom of that. Okay. So
CA cervix is CA cervix would be one.
Niharika has asked you about the postcoital bleeding, intermenstrual bleeding, and
specifically in
yes.
Intermenstrual bleeding, sir, other than submucosal fibroid in a 44-year-old woman, I agree her BMI is on the lower side. So, but suppose if she was an obese lady, what else would you want to rule out?
Any endometrial hyperplasia.
What else could it be? Yes.
Endometrial hyperplasia, and further even a carcinoma.
Yes. So it's very important to rule out those things.
Mm-hmm.
You should understand why you're asking your negative history. All right.
Yeah. And why was this loss of weight and appetite or fever expected?
Mainly in terms of asking for any sort of genital TB also, sir, if there is to rule out genital TB mainly, and loss of weight and appetite with respect to CA as well, so endometrial CA or CA cervix as well, so.
Cancer.
And asking about weight gain, is there a relationship of obesity with fibroids?
Yes, ma'am, because in obese individuals, because there's more of adipose tissue, there's going to be peripheral conversion of the adipose tissue into estradiol, and so hence there's excess estrogen exposure, which is a risk factor for fibroid growth itself.
Other than that, what condition can cause this increase in weight gain because of the per se fibroid?
Sorry, I didn't get you, ma'am.
Per se, the fibroid, can it has an effect on the BMI of the patient? Because it is like fibroid is what secreting tumor? What is the condition it happens? It is a hyperestrogenic state.
Yes. So the chronic anovulation and the other, there is a insulin resistance and the weight gain in that sense.
So it can happen. Okay. And specifically regarding pain, you have not mentioned anything. Whether you have given so many negative history per se, there are many fibroids which can present with pain. So if there is no pain, you should write the negative history that there is no pain, because many of them are asymptomatic also.
She had dysmenorrhea only on day 2 and day 3 of her cycle, which previously she didn't have, ma'am. She with these complaints.
Yeah,
Otherwise,
dysmenorrhea is during the menses, but there are particular type of fibroid which will always continuously, even if she's not bleeding, there is pain. So which type of fibroid usually has pain?
And what is the cause of the pain?
Yeah, and what is the cause of the pain?
It could be due to a subserosal fibroid, which is probably having torsion. It could be due to
Most common, you say?
prostaglandins.
Most common fibroid which will cause pain. It's a continuous pain.
It's submucosal.
Submucous fibroid, ma'am.
Yes, and what is the cause of that pain? Yes, submucosal fibroid. And what is the cause of the pain in submucosal fibroid?
Because it's causing very random contractions of the uterus because of the excess estrogen and progesterone receptors over it. And
that's what happens in examination. You frequently forget the most common thing, that degeneration they will forget. They will study day in and day out. Every time they will study about degeneration, and they will write in the history paper also, I mean the theory paper also. But while asking the questions, when they are asked the question, they will forget about degeneration. Remember, degeneration is a constant happening in the fibroid uterus, constant, because fibroid is always overgrowing its capacity. It has got a very poor, limited blood supply from the uterus, and it always overgrows that blood supply. So degeneration is absolutely common. Sometimes some of the degeneration are not felt by the woman, that means painless, but most of the time it will be felt by the woman as pain. So that's a constant nagging pain that Indranee is asking a very important question. And in exam, you must talk about degeneration.
Yes.
And the degeneration question, that question starts from the hyaline degeneration, goes up to malignant degeneration. So you read about degeneration in between lines to be able to answer questions related to neomyoma. Okay? It's a message for all the students.
Yes, sir. Yes. We'll go on to the next negative history, sir.
Yes. I think we can skip this slide. Is it okay in the faculty? Yes.
Yes.
Okay. It's very unfortunate that no history or record of the treatment is available in this case, although she visited a private hospital, who are usually in general very meticulous about the treatment. They just administered one, iron injection and then let her go without investigating, getting into the uterus or its definitive treatment, either medical or surgical. We'll come to that later. But it's good that you have mentioned that, because it adds to your responsibility in the treating hospital how to take care of this woman. Next slide, please.
Her previous menstrual history, sir.
Yes. Okay, so she had a fairly normal menstrual cycle, I must say, and then on top of that, these things happen.
Menarche has any significant age of menarche?
Early menarche predisposes the patient to more estrogen exposure and hence more chance of risk factors for fibroids.
Early use of contraception, increases chance of infections, sexually transmitted diseases, and it also increases the chance of fibroid because of the prolonged exposure to hormones.
Okay.
Dr. Sangam Jha, are you there?
Yes, sir.
Oh, I can't see you.
That's lit.
Okay, Dr. Sangam Jha.
Yeah.
Any questions for the students from the history and general examination part?
Okay, we'll be moving to, I was listening to you all. So let the slide move on and I'll ask.
Okay.
Till now, it's fine.
Till now, it is okay.
Yes.
So you have got the approval of Dr. Sangam Jha. So one aims we have cleared. Go to the next slide, please.
Yes, sir.
Yes. Anything to comment on these? Just go on moving the slides, and if someone has any point out, then we will raise that.
Okay, sir.
Okay, that's the thing that I was talking about the past treatment history, grossly inadequate, and you can't do anything about it. But it's good that you have put it on record.
So in the past history, you have taken no history of systemic hypertension, right? Diabetes mellitus. So is each history has any significance to your current disease, like what the patient presented with?
Ma'am, if we're taking into account systemic hypertension, diabetes, and if we didn't go to the examination yet, but if this was an obese patient, we would consider the risk of CA endometrium. That was one. Second is having the comorbidities history would help us plan our surgery and plan further modalities of management. Whether we can go ahead if we come to the point of surgery, whether we can go ahead with it or whether we can go for even for medical management, whether hormones can be given or not would be the history of previous medical comorbidities would help in deciding that.
Okay. And this, how does this bronchial asthma, epilepsy? Why you have specifically mentioned these diseases in the past history?
Epilepsy, certain anticoagulants also have AUB effects, ma'am. The bronchial asthma is more of a comorbidity, again, in terms of planning the surgery.
Okay.
I just want to ask, is there any relationship between hypertension and fibroids per se?
I'm not aware of just hypertension.
Hypertension and fibroids go hand in hand, it says. No? There is a direct relationship. No? Both can occur simultaneously. Because the high blood pressure, they will have a damage on the blood vessels. So that also has, it creates a pro-inflammatory environment, and that causes there's an increased risk of fibroids. It's said like that there's a direct relationship between hypertension and uterine fibroids.
Okay, you can move ahead. Show the examination.
What is the another medical disorder that you should be ruling out in a case of fibroid, which is very, very common that we see associated, other than all the things that you mentioned? Hypothyroidism, isn't it?
Hypothyroidism.
Yeah.
We see very commonly patients with fibroid having hypothyroidism. So that is also something you should ask. Yeah, of course, she doesn't have any symptoms suggestive of that, but yeah.
And since we have been taught traditionally that fibroid is a multifocal disease, you should also ask about the breast lump if the patient feels if any. Okay. So negative that is also important.
Yes, sir.
Yes.
Okay, sir.
Of course, that we will find in the examination part, but you must ask the patient whether she or her family, anybody suffered from the breast lump.
Yes, sir.
Yes, sir.
Okay.
Okay, so yes.
Any significant family history? Is it mother or who else?
It's degree relative.
They have 1.5 times risk when it's
also monozygotic twin.
Monozygotic twins, more than the dizygotic twins, they have more common.
Okay. Move ahead, please. Do you want to go to the examination part?
Does the diet have any significance? Diet?
Diet is next slide, I think.
Okay.
Move ahead to the next slide, please.
Yes, sir. An increase in red meat diet will cause more of inflammatory cytokines, and it promotes to an fibroid. Whereas having green leafy vegetables, the anti-inflammatories, more of vitamin C and antioxidant intake, it is told to have a protective effect from fibroids.
Vitamin D also. Vitamin D.
Vitamin D. Yes.
Okay. Since we have time today in our hand, so I would like to examine each and every slide of the students and include or exclude those are the things that are directly related or indirectly associated with this condition. So that is why we are going in detail. Otherwise, we don't normally have time to go through each and every slide. But remember, the exam is not the place where you can show the slide to the examiners. You have to say everything extempore. So you have to remember as much as possible the facts and figures about the woman. And that is why the summary comes into play. You cannot remember of the patient, how much calorie did she consume, how much she required, how much of the protein consumed per day, etc., etc. It is very difficult to remember. People अपना roll number भूल जाते हैं exam में, है ना? So I think that it is very wise to make a good summary and commit to memory that, which will contain minimum amount of, data, minimum amount of data. And there are some guidelines about this. I have prepared something of my own, which will help you talk about the patient, about the case from a summary. So this presentation is very, very important. So whatever we are seeing here is just a demonstration of what should be done. But what should be said in the examination, that is completely different story. Remember that. Okay? Because these sheets will be taken away by the examiner.
Yes, sir.
And then she will ask you most politely, yes, beta, what is your case? Okay.
Yes, sir.
Okay. So diet history is okay. I mean, calorie excess is being consumed. What does it mean?
That the anemia here could not be just due to the heavy menstrual bleeding as well, sir. That I mean, here it is probably only due to the heavy menstrual bleeding, that even the HB 4.1 that she had, the effect of the heavy menstrual bleeding was so high that she had very severe anemia. And if we go to the BMI also later, her BMI is within the normal range, sir. So she's not an underweight patient. So the low socioeconomic status would be that can be noted from this, as well as her overall nutritional status, sir, for further.
Actually, tell you very frankly, this type of dietary history won't help you about the protective foods, vitamins, minerals, nutrients, micronutrients. As a result, what happens to our iron store, iron reserve, we cannot know. How much iron does her diet contain? That still we have to go through by approximation. Like in the crossing, we will ask you what is the total amount of iron a balanced diet usually got by a woman. How much? And then what percentage is absorbed, and whether she's already running a negative iron balance there. I mean, the reason behind this poor hemoglobin or anemia, it could be because of nutritional deficiency, it could be because of specific mineral deficiency, micronutrient deficiency, etc., or a combination of all of them. Okay. So there are many things which are untold here, and they come into the crossing part. Okay. So don't think that only bleeding fibroid is causing the hemoglobin. No, it has a multi-contributory factors. Okay. So, but it's a reasonable attempt that as so far as nutritional things are concerned, I think she is doing reasonably well. Okay.
Yes.
But about the vitamins and minerals and other things, micronutrients, we really don't know. Next. Move ahead.
Yes, sir.
Yes.
To general exam.
Any other personal habits might be a risk factor for fibroid in this modern era?
Alcoholism increases the risk of
Which one?
beer.
Yeah, beer has a more high risk factor, and also caffeine and other this thing, no? Stress.
Yeah. Smoking decreases the risk.
Okay, so all these personal things should be, I think, observed, and they could be noted in specific areas. Okay. So
Yes,
about the examinations, any faculty has got any?
So I want to ask here. There is no edema, you have written, no pedal edema. So other than anemia, in this case, there is no edema. Suppose the patient has a fibroid but 12 gram hemoglobin. Can there be edema in a patient with fibroid?
Yes, ma'am. If we're considering that she's also the edema is more of due to a renal cause, it could be there, ma'am.
What kind?
Hyperproteinemia could be the reason.
No, such a big fibroid, sometimes big
Because
fibroid.
compression, ma'am.
Also
So
the
because of the compression effects, there could be pedal edema.
Yeah, so there are
especially
varicose
the
veins
broad
and
ligament one.
yeah, varicose veins and edema can be. And any skin manifestations, would you want to see anything in the skin here? Is there any relationship, like any skin?
In case
There's
we
a
want to know like
syndrome,
hypothyroidism, like a
Cushing's
Cushing syndrome, striae,
No.
any acanthosis.
No,
like
per se with the fibroid. Is there a syndrome? There's a syndrome associated with fibroid with skin manifestations. Have you heard about Reed syndrome?
Yes. Yeah.
There are cutaneous fibroids. There are skin leiomyomas in the skin, which is again associated with renal cell carcinoma, I think. Yeah, so that's one of the syndrome. It's an autosomal dominant condition. So skin, there might be some skin, though it's a rare condition. So I'm just asking whether there is a relationship. So you did have Reed syndrome.
Okay, so she has an average BMI, no organ involvement, no thyromegaly was noted, normal blood pressure and pulse. Respiration rate, I think you should write here. Respiration is an important
Okay.
thing.
Yeah.
So you move ahead then. Okay.
Yes,
Sir,
sir.
I just wanted, like, the patient had gone to 4.6 with no medication, and you have just written Pallor plus. Probably she would have been more anemic if you could have, because your severity of anemia and 16 weeks fibroid is not actually matching with your clinical symptoms.
Yeah, I agree you to some extent, Meeta, but then, it's something maybe happening because largely because of the absence of data that we have, whatever happened since that observation of 4.1 and today, nothing is on record, nothing is available. Maybe that she has taken some medications which she hasn't produced the records, or maybe had some iron, etc., which has marginally improved or something like that. So whatever the students have observed,
Yes, sir.
that we have to, believe. Because, दो चीज पे हम लोग संदेह नहीं करते. एक तो woman's age, and the two is the second, is the examiner's findings. Whatever they say, you have to accept that. Okay, so systemic examination is over. Largely, she has a non-disturbing systemic examination. Okay. Next. Yes. Here, we want to add anything or something sounds redundant?
"16 weeks fibroid, lump should have been there."
On inspection, there was not seen. She was thin build, but still it was not.
She had
In
a
inspection, even on inspection, you would feel that bulge, na?
At least.
That should
Correct.
have been
And
visible.
Neeta, I also agree with you. And also note that the patient doesn't have any symptom of heaviness in the lower abdomen or lumpy feel in the lower abdomen. That is also a bit surprising, but it may happen, As I said, whatever the patient says, you have to believe in that. And since she hasn't complained about lump abdomen or heaviness in the lower abdomen, you have to accept that. But not being able to identify that in inspection or a palpation is something which is important. So on inspection, it may not be visible that much, but palpation we are waiting for.
Yes, sir. Yes, sir. Palpation we were able to feel.
Yeah.
Sir,
Okay.
a 16 weeks fibroid, they have to, matlab, it would be visible, sir, on inspection also.
It should be. That
the
is
tube
why
does-
it was not visible, and so
Especially
they're
because she's
worried
very
about
thin. She's not
that's
obese.
why, that's why they are worried about the full bladder.
Ma'am, in thin women, it will be more visible, I guess. In
Yeah.
obese, it's difficult.
Correct. Yes. So I think that this is a description of a mass as far as possible. It should be detailed, elaborate, and as much information that can be gained from examination that should be mentioned here. Sometimes we give extra, but description of a mass by a postgraduate cannot be, just a elementary observation. It has to be very specific. Sometimes with a point of centimeter to centimeter. And sometimes the examiners may not like this pregnant uterus size corresponding to 16 inch pregnant uterus size. You have to give it in centimeter. So 16 centimeter or into 10 centimeter or something like that will be better for your own benefit. Okay.
Okay.
And clinically, how would you differentiate this mass from, say, an ovarian mass on examination?
On examination, if it was an ovarian mass, usually we'll be able to feel on a bimanual examination, we'll be able to feel a groove sign, ma'am, that is seen between the mass and the uterus, and there won't be any transmitted mobility that will be seen to the cervix.
see, Dr. Niharika's question was very, very important and a very frequent question in examination, I must say. So in response to this type of question, how do you clinically differentiate between an uterine mass and an ovarian mass? Very common clinical question. In response to that, you must be prepared to start like this. Sir, or madam, whatever it is, I need both abdominal as well as bimanual examination for this. You start like this and see the difference. The examiner's difference, our face will light up. Yes, this is the way to answer. Whereas when you are dealing with the per-abdomen examination, you may not be able to differentiate with all the features between abdominal and uterine and ovarian mass. But that is why you say, at the beginning you say that I will need, on top of the abdominal examination, also a bimanual examination for the differentiation. Because both are clinical examination. You cannot say that I will need an ultrasound.
Yeah.
Okay.
Yes.
So this is the difference in
Exactly.
answering questions that actually interest the examiner. Okay. Yes, Dr. Niharika, go ahead. Are you happy with the answer?
So, sir, they should start from the history, to differentiate between a
Of course.
fibroid. It should
History is
start from the
also,
history.
history is also included in the clinical part. So
Yeah.
I think apart from ultrasound or MRI, they can include anything.
Everything they can include.
That in the mass description, you have not mentioned about the consistency, whether it's a firm, hard, cystic, tensistic, what?
They're
Very
written
important. Very
Firm,
important.
irregularly enlarged mass.
You should have mentioned this. You have written just irregularly enlarged. And irregularly enlarged, what do you mean by this?
It doesn't make any real sense. Irregularly enlarged, you have to define it properly. There is nothing called irregularly enlarged. Form is okay, but irregularly enlarged means what? I also ask you this question. What is the meaning of
Asymmetrically, sir. It's not a globular mass, but it's asymmetrically enlarged, sir. The
That
symmetry
means
is
margins are not regular. That's what you mean to say, isn't it? So write that specifically.
So they have written a smooth margin.
smooth margins again.
But irregularly enlarged means the mass has to be nodular. Na? Multiple fibroid will present like this, having a multiple, there will be different, here you will find another bump, then again you have a next to it another bigger bump, then a smaller bump. That's a irregular thing.
Yeah. I think
And that goes in favor of adnexal mass. And
Correct.
adnexal with the malignancy, they will have a nodular mass, and that will be irregular margin.
Correct. So in exam, don't mention something which creates controversy among the examiners. So they will be busy discussing among themselves, what does she mean actually this? So your attention or focus on you will be gone. Okay. So whatever you feel like, whatever you have the finding in the mass, mention it clearly. Sometimes in plain language. Okay. So that's very important. So don't mention some ambiguous terms like irregularly enlarged. Okay. What is the second line like? Just read it out. Extending from the suprapubic area and occupying the suprapubic area means?
It's arising.
It is arising from the suprapubic area and it is occupying the two lower quadrants, the suprapubic area and the right iliac area.
Okay. So there is no mention of the right iliac area. Have you noted? Have you mentioned here?
Yes, sir.
Oh, yes, right iliac area is here. Okay.
And then you have mentioned lower border of mass not palpable separately. Separate from what?
From the mass itself. It is arising from the pelvis. It appears like it's arising from the pelvis. So the lower border is not palpable.
Palpable. You are not able to reach beyond the lower pole or lower margin.
Lower
What you see.
border.
So
yeah, I think they mean that only, yes, Dr. Sangam.
Yes, sir.
They mean that the lower border of the mass is not palpable. Full stop. Don't try to create separation in the mass. Divisive attitude. Okay.
Otherwise, it's okay. Yeah. Can move ahead.
Move ahead. As I said, I I think I have mentioned in the beginning that the breast examination is, I think, missing here.
No, sir.
Yeah.
Yeah, they
General
have mentioned,
examination, we are
yeah.
told breast examinations.
I think in such cases, you can have a breast examination separately also. Anyway, the patient doesn't have any complaints. So, breast, what have you written? Breast
They have,
examination.
they have written breast examination normal.
Okay. 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 Breast examination is normal, particularly no lump noted or no lump felt. These words are, good in a case of fibroid uterus.
Yes, sir.
Many examiners have different अपना viewpoint होता है. So better to be negative. So many negatives we are giving. एक और negative add करने में क्या आ जाता है ना? No lump palpable. Okay. So go to the local examination slide. Yes. Per speculum examination and bimanual examination. So tell me, this PV examination and bimanual examination, what is the difference?
So in PV, we would just it is primarily only a per vaginal examination where we feel for the fornices and the cervix as such. So with bimanual, we would be able to feel the size of the uterus, the feel of the uterus, the consistency, as well as even the retroversion and the anteversion is noted better with the bimanual examination compared to just PV. So. And PV also, we would feel the parametrium, the vaginal side walls. In bimanual, it's mostly about the uterus and the cervix.
These are all elementary questions that troubles the students. Actually, I remember Dr. Ashok Kumar's class in the very beginning. He has elaborated on all these things. See, parvaginal examination as such, the par speculum is also parvaginal examination. So parvaginal examination as such doesn't mean anything. So students must be very clear to say that, because from the experience of 3 years, you have come to know that unless and until done bimanually, PV examination doesn't hold any importance at all. Yes. So that is why par speculum examination is also PV examination. You can write a broad heading PV, and then you write par speculum examination, and then vaginal inspection, or if it is necessary, and then bimanual examination. Okay. So anyway, bimanual examination, you have written everything more or less. Anything missing there, Indrani or Dr. Sangam? Or Dr. Nita? You want to add something on this?
So that irregularly enlarged, still not what that irregularly word means when you're doing a size, when you're assessing the size of the uterus. Bimanual examination gives us the idea about the size of the uterus. So irregularly enlarged means what did you find in that? What do you feel means, like, why are you writing the word irregularly?
Yeah, the controversy which arose in the abdominal examination persists in the vaginal examination also. That's the meaning of
they might have an answer to that irregularly, because they're keeping on using the word.
Oh,
what is your
for
answer?
the term asymmetrical enlargement, we want to mean that, ma'am, by that irregularly enlarged.
So there's a lot of difference. Once you use the word irregular, a lot of other things comes. So you have to be very specific on what adjectives you're using to describe your lump or the tumor, whatever. The adjectives have to be proper. So I feel that irregularly word is not. You can say asymmetrically enlarged. Then that would be a more appropriate term.
More accurate, right?
So students, do you agree? Yes.
Yes.
Change the terminology. Okay.
Yes,
as I said, nothing ambiguous should be kept in the exam sheet.
Yes.
Okay. So I'm talking about the other findings, like the size of the uterus. Should it be mentioned? Yes, it is mentioned to 16-week size. Mass fell through the right fornix. Here, the uterine size by bimanual examination, it must be in the pregnant uterus size only. Here you cannot say a centimeter. Okay. That's what I wanted to say. This is difference between the abdominal and bimanual examination. In abdominal, you can mention it is 16 centimeter into 10 centimeter into 4 centimeter, something like that. But in vaginal examination or bimanual examination, you have to say that it is up to pregnant uterus size. Okay, that is permissible. Then mass fell through the right fornix. Other fornixes free. Be specific. Over the posterior and the left lateral fornix are free. Anterior fornix free. No fornicial tendons, isn't it? And transmitted mobility from cervix is there. No groove fell between the uterus and the mass. Anything else you want, our examiners?
That's fine.
No, sir, it appears.
Do you need
Again,
to
the consistency also you will be able to feel in the biomanual, right? When we
firm
whether it's a firm mass
and also if the procedure is tender,
or a
you should
cystic
also
mass.
mention the tenderness.
Okay, sir.
Okay.
Yes, sir.
Just add these two things.
Yes, sir. Yes, sir.
Next, move ahead.
Summary. This
Yes,
would have been
summary.
summary.
You have to make the summary and summary of the history part, summary of the general examination part, summary of the local examination part, and then you come to the provisional diagnosis. The summary was missing here. And
Sir, please, sir, why did they write probable FIGO 2/5?
Yeah.
Yeah, that's
I also had that same question.
You have not done any ultrasound. Where did you write from there?
They wanted to express their knowledge.
So the complaints of being heavy menstrual bleeding and dysmenorrhea,
No.
Rita,
see, the first thing is if you've done something wrong, please do not justify you're wrong. Say, okay,
The
sorry,
first
we
question-
accept, it's okay.
First question in crossing comes from Dr. Meeta Gupta. Be prepared for that. About the relationship of the ego staging and the symptomatology. Okay. So probable case, first of all, see, I don't like this term probable case. It is a case of abnormal uterine bleeding. There is no doubt about that. And on top of that, you have the heading called provisional diagnosis. Whatever you say here is provisional. Then why do you write probable? If you think that it is, then you mention it and then you substantiate it with your findings, with your investigations, which are coming later on. Okay, they're not part of the clinical examination. But always writing probable, being very humble, and also adding some another probable like FIGO, calling FIGO unnecessarily in the middle, FIGO will mind, isn't it? Okay, so delete that second part and write a summary before this provisional diagnosis.
Okay.
So now,
Yes, tell us. Differential diagnosis already, we had started our discussion with the differential diagnosis, so we will omit that discussion. Now let us come to the crossing part. Crossing is a good, 20 minutes we can devote for crossing. So the first crossing is from Dr. Meeta Gupta. Yes.
so how will you manage this patient?
Sir, we will first admit the patient and do her basic blood investigation of a complete blood count, and also look for a transvaginal ultrasound can be done, transvaginal or a transabdominal as well, because it's 16 weeks. A transvaginal or transabdominal ultrasound to see what is the pathology, to observe what is the pathology, and based on that we can do further investigations and further other imaging or further other routine investigations can be planned based on that. As she's already a patient who is anemic.
Betu, you are a third year PG. You've done an ultrasound. You now tell me it is FIGO 2/5. Done? Your investigations, please tell me what investigations, blood, this thing. Please be very precise. As a third year, you're sitting in a practice and this patient comes to you. What investigations you will advise?
Complete blood count, ma'am, mainly to see the anemia. She's already pale. Apart from that, I would send her blood for cross matching as well to plan for a transfusion. And apart from that, she does not have symptoms pertaining to hypothyroidism, but we could also do a thyroid function test because she's not been evaluated properly before. Apart from that, again, as the patient is on irregular follow-up, I would do further testing for diabetes and hypertension as well because she's at that age group currently. And diabetes by doing a HbA1c or an RBS can be done. And based on these investigations, again, we will take the further call to do further investigations or not for a pre-op assessment or anything, ma'am. But these are the primary ones that I would do.
So you did it and an opportunity of, window of opportunity you got and you evaluated the patient for all the non-communicable diseases like diabetes, hypertension and all. What other thing you would like to investigate in this patient as an opportunity? 44-year female.
Pap smear, ma'am. A cervical
Very
smear
good.
screening should be done as well.
Done. So now that you have everything, she's a diagnosed lump. ET patient is, you said her LMP was 15th of June. Today again it is 15th or 16th. Her endometrial thickness is 14 or let's say 16 mm. Now tell me, what is your first investigation of choice? Now what will you do?
As she's approaching 45 years and she is having persistent AUB, but not really medically managed, but we could do an endometrial endometrial aspiration, endometrial pipple biopsy can be done for her on as a daycare procedure to observe what is the status of her endometrium currently, ma'am.
Good. I'll hand over to the other examiners to take it forward, please.
Yeah. So, any other investigations before you come for the management? You'll do an endometrial biopsy. Do you like to do a mapping of the fibroids before you?
Based on the ultrasound, ma'am, it is not a routine thing to do mapping via an MRI, but based on the ultrasound, if required, we can go for that. Again, if you are planning surgery or if you're planning any other modality, then we would go for it, ma'am. We can do
So
an
it is
MRI.
not mandatory.
It is not
Depending
mandatory.
upon the ultrasound report, you decide whether.
Yes.
So in this case,
You can do the ultrasound guided mapping as well. You don't need an MRI really. If you have a
MRI,
good 3D ultrasound, you can do a decent mapping even
3D
with that.
ultrasound will also do the.
Yes, ma'am.
Because you
Yeah.
need to plan if you need to plan your surgery, you have to have that mapping in your mind. Then, so what kind of management are you planning for this patient?
Yeah, this is about yeah. Ma'am, for her, based on the kind of fibroid, first we can plan if it is not a cavity distorting fibroid, and if the endometrial biopsy is also not indicative of any atypia or malignancy, then we could probably plan her for Mirena insertion, ma'am, so that there is a more, because she's a PERS patient who's also on irregular follow-up. She's also
What
been
size of uterus is there?
Yeah.
16 weeks. We ideally not.
No, you
What
have to be
size of
definite
uterus
in
is
your
this?
answers. See,
Can you
you
put
are
the
you are
minimum
going to
for her?
become like you are going to pass out in a few months. So I might do this, I might do that. So that should not be answer. So you have to tell me I will do this. So if you're saying Mirena, then you justify why you are wanting to put Mirena. Will that solve the problem?
Yes, ma'am, it may solve the problem because she will approach menopause in a few years. So up till then, to control the bleeding and to improve her anemia status, we can
So
place a
she's
Mirena, ma'am.
44 years, so she might, another 6 years, she might not attain menopause. So even if you might look till 60 years, she might not, 50 years, she might not attain menopause. So her fibroid size is 16-week size. So that's quite a big fibroid, right?
Yes, ma'am.
Mirena might solve her heavy menstrual bleeding, but what will happen to the fibroid?
It's there is no effect on the fibroid as such. It is only going to decrease the bleeding complaints primarily. There is no shrinkage in the volume. So in that case, if she is also willing for surgery, then we can again, before that, if she is not willing for surgery, I will give her GnRH analogs that can again
You'll
decrease
give
the size.
GnRH analog.
No, first.
Your first line treatment is GnRH analog.
The first line treatment is antifibrinolytics and the NSAIDs, ma'am. But considering she's having recurrent AUB and this is almost chronic AUB, hence, will she be compliant with that medication is a question. So then we have to go to the next modality where she's not going to be, she won't come back with these persistent symptoms, ma'am.
Indrani, you can ask them that suppose a typical case like this, 16-week fibroid uterus in a 44 years old lady, multiparous lady, what is the typical words of counseling that you do with this kind of a woman and her husband? That is very important because they have to do after passing out, isn't it? So suppose one patient in front of you, this patient is in front of you, and they have come for the counseling. And now, how do you counsel them? What kind of treatment is available after doing all the investigation, sharing the reports of the investigation with them and their implication thereby? And then how do you propose to, manage this case and counsel them? How do you do that? Instead of going separately by each medical management avenues, you can start by saying that there are two methods of acceptable modes of management. One is medical, another is surgical. Now, आगे आप बोलो, कैसे बोलोगे? How will you counsel the woman and her husband? typical
Yes, sir.
case like this?
We'll counsel the patient about the various modalities available, about the medical managements and the surgical management. If the woman is willing for medical management, we'll first start with antifibrinolytics and NSAIDs to control her heavy menstrual bleeding, sir. And side by side, we have to correct her anemia also, because the patient is having breathlessness and fatigue. And if it is not getting controlled, we can try the hormonal methods, which are our ocipils and progestogens, which we commonly use. If the patient is not compliant and it is not getting controlled, if by the medical methods the bleeding is not controlled, they'll counsel her for surgical managements. In surgical management, if she wants to preserve her uterus,
Wait a minute. The basic question still remains unanswered. Like Indrani said, what happens with the fibroid? Patient is all ears about the fibroid because she's worried about the tumor, about the probability of cancer, etc., etc.
Yeah, she might tell that is something bad might happen or what? After 1 year, something might happen to this fibroid. How will you go about counseling her?
I think you can say all this what you said, but add with that however it will reduce the bleeding only, but without
and it will not reduce the size of the fibroid.
But fortunately, these type of cancers usually have a very poor rate of malignancy, very low rate of malignancy.
0.2%.
So that will be actually reassuring them, and then they will give all ears to you about the different modalities of treatment. Otherwise, ab tak wo nahi sun raha tha. She was only hearing that part about the fibroid uterus, about the cure of the symptoms, etc. But she was not listening to you properly unless and until you tell them that this will reduce the bleeding and correct your menstrual blood loss. But unfortunately, it won't do anything about the tumor. However, these type of tumors have a very poor rate of malignancy, poor chance of malignancy. In your own language, in your local language, you can say that. And that will assure her to the extent that now she will listen to all the options. Once the fear of malignancy is gone from her mind, she will be attentive to your counseling. Okay, so just slightly modify these sentences. That yes, now we know that this type of tumors have got a very low rate of malignancy, and the treatment that the medical management that we usually give, they have impact on the blood loss, but the fibroid or the tumor remains all right, remains same. Now the second option is the surgical management. There also you classify between the two things. One is the sudden menopause, and the second is about the chance of malignancy and the extent of treatment. So this is the way I think a typical case mix in your institution. You can plan this, how to counsel a woman like this on different questions, and then only they should be able to take a decision. We frequently say that the patient's wish, choice, etc. But most of the time, the patient depends on you. Give her option, give her choice. So you have to explain properly, elaborately, in proper terminologies, in their own language. Otherwise, they won't be able to give you option. Because in the end, she will say, whatever you feel better for her, please do this, sir. They will do that, isn't it?
And that's the most common answer. And I think while counseling the patient, you should be transparent. You should give the success rate of your whatever treatment you are offering. Suppose they have in mind, like these fibroids are very slow growing tumors, na? So you have to give a percentage, like for suppose they'll ask you, if I take this medicine for 1 year, what will happen to my fibroid? And like, what are the other side effects? So you have to be very transparent in counseling. You give all the option, failure rate, success rate, what are the other options available after this treatment, and then they will choose. But you have to give all the percent. Like sir has very rightly pointed out, you must tell them that this is the percentage of cancer that can happen if I leave you without any treatment. So that has to be counseled, and these points should be considered in this thing. Secondly, in your while managing this case, you said you will admit this patient. So why you want to admit this patient? because our hospital are always overloaded with the patient, and just for investigation, why you want to admit this patient? In your history, you said pallor is 1+. Second, but her complaint is fatigue and breathlessness on exertion. Okay?
More so for
That,
the
that
anemia
two
correction,
are
but
not
yes.
matching.
Yes, ma'am.
So why you want to admit the patient? Justify it.
More so for a
admission is
possible.
justified, yes. Now tell us, what are the justifications in favor of admission? एक तो justification ये है कि this is a long case. Long cases have to be admitted. But you cannot say that, sir, for examination purpose, I'll admit her. You cannot say that. Please, for heaven's sake, don't give this answer to the examiner. They get irritated, you know.
For mainly for
Yes, yes, go ahead. Yes.
mainly for if there was severe pallor, then mainly for the anemia correction, sir. Also, secondly, again, because she has been on irregular follow-up, to prevent further sort of loss of follow-up, we could do the workup in the hospital. Again, depending on the type of hospital and the affordability and the patient's status, other willingness. But in this case, it will be primarily for anemia correction and evaluation. Otherwise, this all can be done as in an OPD basis, all the other further evaluations.
Okay.
And I think if pallor is 1+ and still she is breathless on exertion, you should evaluate her cardiac system also. You know, with the pallor,
have to
1
rule
means
out
hardly
CCS.
it will be around 10. So patient with HB10 will not have breathlessness on exertion.
This is for a general, this thing for all the students present here, that, so far we have been depending or relying heavily on the hemoglobin for the estimation of a degree of anemia. Unfortunately, this is very wrong. You know, a woman who has developed some disease or comorbid condition over a period of time, say 10 years, 15 years, will give the hemoglobin, at the fag end of the, deficiency status, the hemoglobin will fall. But before that, the hemoglobin status, the iron store and the iron, requirement, etc., all these, they go on drastically below. And that is why today we advise most of our women CBC, complete blood count. Now tell us, what are the things that you get from CBC which will justify the diagnosis of anemia? Today, if you ask the hematologist, they will always depend on CBC for the diagnosis of the anemia. But gynecologists often prefer the hemoglobin percent for that, which is a late finding. So you need to know what are the findings in CBC that will help you in the diagnosis of anemia. I mean, iron deficiency anemia, the commonest in our country, or the other causes of anemia. What are the clues that you get from CBC? You're doing it regularly, no, in the hospital.
Yes, sir. So the hematocrit will be decreased, sir. The mean corpuscular volume will be decreased in case of an iron deficiency anemia. Also, the MCH and MCHC will also be, corpuscular hemoglobin concentration will also be decreased.
So these are red cell indices. Okay.
Yes, sir.
Fine. Then, what else do you get from CBC?
Red cell distribution width also.
The RDW width, the red cell distribution width will also be noted. So increase in RDW will be denotory of an iron deficiency anemia.
What happens in RDW, increases or decreases? Can you tell us the value? Have you gone through the reports? RDW value, red cell distribution width.
Protein. 215. Proteins.
Normal is 14 or something like that, but in
Yes, sir, 14.
anemia, it can goes up to 17, isn't it?
Yes, sir.
So that is the first index of suspicion that this is a case of iron deficiency anemia. So before going in for iron studies, if you can have a look at the RDW or the CBC findings, then you can find out whether this patient may be a case of thalassemia also, because there the RDW remains low. So I think then you can calculate from the Menzer index, or you can go from the HPLC study, etc., etc. So there are different types of anemia you can diagnose with the help of CBC. But CBC is the first point of investigation in anemia. Don't forget this in your examination.
Yes.
This is by the way I said. Coming back to the case now. Yes. Dr. Niharika and Dr. Indrani. Dr. Meeta, any other question? We still have 2 or 3 minutes left for the discussion.
So if you go for surgical management, what will be your preferred choice of surgical management? And one thing I just want to say, when you start saying, no, you start from very simple things, no, when you're saying, like how you said GnRH analog, no, GnRH analog is there, but when you start, you should start with the simple things and then you go step by step to the higher things. Always in an exam, you answer like that, okay?
Which
So tell
we
me.
commonly use, you commonly prescribe. Okay?
And
So,
moreover, GnRH analogs is temporary, no? It is only for the
Yes.
reducing the size of the fiber when you prepare for a surgery, and it is not a permanent, it always recurs and you cannot give for more than 6 months. So
Yes.
this cannot be a first line of management.
Okay. So that's decided that we won't
Yes.
take GnRH analog in the first line of management. Okay. Then now coming to the planning about surgery. I want some questions on myomectomy and some questions on hysterectomy, etc., etc.
Yeah. So
Are
tell
there
us.
any
Yeah.
what will you plan? Hysterectomy or
For
myomectomy?
this patient, what would you do? Since she is in the borderline and the perimenopausal age group, we could advise her for a hysterectomy, ma'am. We can give her the options of a laparoscopic hysterectomy, which may or may not be converted to an open hysterectomy, ma'am.
So both can be correct, but you need to justify each and both of the options. Just justify it.
When would you consider open and when would you do the laparoscopy? That's what ma'am is asking. If these basically if we if there are the risk of adhesions, the risk of the risk of uncontrolled bleeding is high, there's distortion of anatomy, then we could consider more of the open.
What is the single most deciding
Huh.
factor to decide whether you will do an open hysterectomy or a laparoscopic hysterectomy? What is the one important factor? Huh? Pardon?
The size of the fibroid.
No, it is not the size of the fibroid. Somebody can do a 30-week size fibroid, also can do a total laparoscopic. It is only the skill of the surgeon. It is the most important thing is the skill of the surgeon.
Yes.
Yeah.
Skill of the surgeon. Yes. And the facilities available at the unit. That is all.
Skill of the surgeon and bill of the hospital. Okay. Now, since we have another session on myomectomy across eras, and to be taken by Dr. Anupama Bahadur. So we can leave this part of discussion a bit here, but you can go asking about generally about myomectomy, selective myomectomy, or how many, what is the size, what is the limiting size of the uterus, etc., etc. Is there any limiting size for preventing myomectomy, or a number of fibroids that will limit the myomectomy? Is there any such rule?
No, sir.
No such rules. So you can take out 125 myomas if, at a go, single go, if you find the places to keep them, isn't it? Okay, so that is important, that there is no such hard and fast rules. But in general, the ultimate aim of myomectomy should be to give the patient a reasonably well-formed, good-looking
uterus for some more.
It is not a deformed uterus that you present at the end of a prolonged myomectomy and say that I've done a wonderful job. So that is also another important thing about myomectomy. Okay.
So one question, sir. What are the
Yes.
measures to reduce the bleeding during myomectomy?
Yes.
The installation of vasopressin, which is usually 20 units or 1 ampule in 200 ml of saline, it's installed. Or we can also do hydrodissection, which may also help.
That is intraoperative. I think efforts to reduce the bleeding starts preoperatively.
Preoperatively, we can give her, gonadotropin receptor analogs to decrease the vascularity, ma'am, primarily.
Most important, what should be the timing of the surgery? What should be the timing of the surgery in the menstrual cycle?
It should be in the follicular phase, ma'am, when the endometrium is thin and it is.
So it should be done premenstrually. That is one cause which will reduce the bleeding if you do. Sorry, means I mean not
Immediately post-menstrual.
Immediately after the mens, you should plan your
Menstrual.
surgery.
Actually, relationship with the menstrual cycle is important because the students keep calling her perimenopausal. I don't know why they're after her menopause. She's leading a strong life, having a normal menstrual cycle. Nowadays, we do not define perimenopause by age. Okay, there are multiple factors which will determine whether she's perimenopausal or not. So, okay, do not call her perimenopausal. Okay, she might not like. Anyhow, so the number of fibroid is not a bar. Site of the fibroid is not a bar. You can go for myomectomy. But before the procedure, you talked about GnRH analog to reduce the size of the myoma. It has got another disadvantage also.
Yeah.
The plane of cleavage will be lost, sir.
Plane of cleavage is lost. Okay. Now,
Yes.
after the procedure, myomectomy is over and having a good-looking uterus, not deformed uterus, then post-operatively, how do you manage this? Do you give this GnRH analog or antagonist or whatever it is? Or you just keep her a prolonged follow-up? What do you do?
Actually, what we've done is we've kept her on regular follow-up. Right? Our hospital has case.
So post-operative
Regular
GnRH
follow-up.
is no longer recommended that much, because it was given originally with the idea that myomas, the seedling myomas, and all myomas cannot be excised. So for the small size myomas or the pin size myomas, we recommended post-operative GnRH analog, but that hasn't been able to give the desired result. So preoperative is okay, but post-operative we do not recommend these days. Okay.
And one more thing, you have done a myomectomy for a huge fibroid. You have planned, and then the patient had heavy menstrual bleeding. So will her heavy menstrual bleeding disappear from the next cycle after you do the myomectomy? Because she has come to you with heavy menstrual bleeding. So you will be able to achieve that after the myomectomy? Means next cycle she'll have normal mens, or what? Or if there is no normal mens, if there is heavy mens, how are you going to counsel the patient? First, you tell me whether the cycle will become absolutely normal after the myomectomy, next cycle.
In other words, does it depend on the site of the myomas, where the myomas are placed, what type of myoma is there, on the basis of which you will counsel the woman, that whether after the operation your menstrual cycle will be resumed as far normal as possible. That's what she's asking. So do you expect that?
So it would not, with respect to the fibroid, if this was, of course, a subserosal fibroid or which was operated on, the resumption of normal menses would happen from the next cycle now. But
Suppose this big fibroid, fundal big fibroid, you have done a myomectomy for whose fertility preserving myomectomy. So the menstrual cycles will become normal. Next cycle, the heavy menstrual bleeding will stop. So why it will not stop? Why it will not stop? How long it will stay? Because what is the reason for that? Why will the heavy menstrual bleeding not stop immediately after myomectomy? Intramural fibroid. Because?
The inflammatory factors have to be will have to decrease, and also the uterine contractility has to be it will take around 3 to 6 months of time for it to improve.
Because there is myohyperplasia. Along with the fibroid, there is myohyperplasia. So it takes around 2 to 3 cycles. So immediately you should first counsel the patient. Whenever you go for myomectomy, you should tell the patient that your bleeding cycles will be resumed 3 to 6 months, around 3 months after I do the myomectomy. In those periods, she might need some conservative management, and the myohyperplasia will slowly come back, reduce, so that the bleeding also stops in a few subsequent cycles. So counseling is very important before you do the surgery, because patient has come to you with heavy menstrual bleeding. No, she will expect that next month everything will be fine.
Yes. Okay, ma'am.
Okay, so I think we have come to the end of our discussion because we don't have much time now. We have to go to the next session. In the meantime, there are some questions and observations in the chat box. I'll read it out for you. Dr. Rubina Fatima is saying, if fibroid undergoes degeneration, red degeneration also. That was in answer to the question about the complication that Indrani raised. Then Dr. Yashodhara Pradeep says, it is mentioned that this woman had last delivery 19 years ago, neither used conceived method nor conceived what would be the reason. I mean, she means contraceptive. The presenters might have missed to evaluate barrier method and natural method abortion self-use of medical method for abortion. Maybe, yes, possible. Contraceptive methods, whether she has used or not. And the history says that she hasn't used any contraceptive. Okay. So I think in absence of any other question and with permission from all the faculty members, I would like to end this discussion here. Excellent discussion. And the students have already passed. They're waiting for the 65 to 70% marks now. They're that category. And this is the right time to call upon Dr. Anupama Bahadur. Madam, are you ready with your presentation? So
Yes,
thank
you, sir. Thank you, sir, so much for this opportunity.
Yeah,
I want
yeah.
to thank
Yeah.
everyone.
So much. It was a
Thank you,
pleasure.
everyone, and thank you, sir. You made this discussion
Thank you
very
so much.
interesting, and you have put in some. कहते हो थोड़ा हंसी मजाक डाला आपने.
Sir का sense of humor ही ऐसा है.
Yeah, you have put in a humor. That's what. Yeah, very
Sir, we have
excellent presentation by the PG student.
Yes, sir. The students did extremely well. That is what we thank them because thank you so much. Thank you, everyone.
Yes, sir.
Thank you so much.
Hafizur, please invite Dr. Anupama Bahadur and have the discussion. Are you there, Hafizur?
Yes, sir, I am there.
Yes.
Thank you so much, sir. And thank you all the faculties, Dr. Mita, Dr. Indrani, and Dr. Niharika. Next section, I'd like to have as stage Dr. Anupama Bahadur. She is going to speak on myomectomy across the eras, that is open, laparoscopic, and robotic approaches. So Dr. Anupama is professor and unit head at the Department of Obstetrics and Gynecology at AIIMS Rishikesh. Dr. Anupama, over to you.
Thank you, sir. Are my slides visible?
Yeah, visible.
Yes, ma'am.
Okay, and you can hear me as well. Thank you so much, FOGSI ICOG, for inviting me to this prestigious FOGSI PG clinic. Honored and humbled. Thank you, Dr. Mukhopadhyay and Dr. Hafizur Rahman. So it has been a very interesting PG discussion, and I must say that my life has been made easier because most of the things have already been covered. However, I'll take you through this journey of myomectomy across eras, comparative of open, laparoscopic, and robotic approaches. So the choice of the procedure, either you can have the traditional surgical method, that is abdominal myomectomy, which is otherwise open myomectomy. If a person is good at non-descent vaginal hysterectomy, then even that can be attempted, abdominal or vaginal hysterectomy. As far as the minimally invasive surgery is concerned, hysteroscopic myomectomy, lap myomectomy, or lap hysterectomy, depending on the age, the symptoms, and the desire for fertility, as well as one can go ahead in this present era of robotic with a robotic myomectomy or robotic hysterectomy. Now, as far as the treatment is concerned, it is mainly symptom-based. The patient, as has been discussed in the previous case as well, they come either with heavy menstrual bleeding, which can be managed medically, and if it fails, then one needs to intervene, or if the patient wants a surgical management and if she is a candidate fit for surgery, we go ahead with a surgical treatment. Patient generally comes either with heavy menstrual bleeding or bulk-related symptoms, or the women who are desirous of a future pregnancy. In them, myomectomy is the procedure of choice. However, for the benefit of postgraduates and for all the clinicians, whenever in the best of hands also, if you're doing a myomectomy, please explain it to the patient that there is a slight chance of her landing into hysterectomy. As far as the preoperative evaluation is concerned, Sir had mentioned about a complete hemogram. One needs to decide, depending on the hemoglobin, whether she requires pre-op optimization. That is, as far as her hemoglobin is concerned, if it is less than 10, then the anemia needs to be corrected. Her kidney function test, liver function test, sugars, fasting and postprandial, chest X-ray, ECG, the viral markers, They're all very important as far as the pre-anesthetic checkup is concerned. The specific investigations include ultrasound for mapping of the fibroids. You should know exactly the size of the fibroid, the number of the fibroid, whether it is degenerated or not, and if at all it is a submucous fibroid, histoscopy can be done for them, and endometrial sampling to rule out any endometrial pathology. And in patients who come to us with infertility, remember to work up the partner, because you need to know the counts, the motility, etc. And you have to rule out the other causes of infertility. We have seen that fibroids, they exist with endometriosis, adenomyosis. So you have to rule out the tubal factor, the male factor, etc., etc. As I've already mentioned, that the anemia should be corrected, because with a hemoglobin less than 10 grams per deciliter, there is an increased morbidity almost to the tune of threefold. The discussion did lead to GnRH agonist, which decreases the blood loss as well as the uterine size, gives us time to bide over. But remember that the plane is lost, and now, along with GnRH and agonist, even the antagonists have entered the market and are being used. So I think Dr. Indrani had asked this question, that when should the surgery be scheduled? Obviously, in the follicular phase. This presentation will not be complete without mentioning Dr. Victor Boni, who we all know is the father of myomectomy, and most of us are very familiar with Boni's myomectomy clamp. And also remember that these two instruments, the Boni's myomectomy clamp and Doyen myoma screw, these are the true instruments that we use routinely in our surgery. However, Boni's is used in open myomectomy, and Doyen's myoma screw in open as well as in minimally invasive route. So coming to the basic principles of myomectomy, remember there has to be an optimal exposure at the operative site. The principles of microsurgery must be followed. Blood loss should be minimal. The incision has to be carefully planned out, because with a minimum number of incisions, when there are multiple fibroids, you have to take out the maximum number of fibroids using tunneling technique. Or you can even use the Boni-Hood's technique, the incision, which is a transverse elliptical incision for posterior fundal myoma. The identification and dissection has to be along the pseudocapsule, repairing the defect by using a multi-layered approach, so that we close or we approximate as good as possible. And there is definitely a role of adhesion barriers. So what is the role of MIS? Having spoken about open myomectomy, we now move on to the role of minimally invasive surgery in complex myomectomy and in planning the surgery. So when there is a morbidly obese patient, the uterine size is more than 22 weeks, there are large fibroids, more than 10 centimeters in size, more than 5 in numbers, or there is concurrent endometriosis, she's received prior medical therapy, which has I said it can distort the surgical planes. And when there is an inability to use a uterine manipulator because of the cavity distortion and inability to grasp the cervix from below, then it has a place. As well as, again, it was mentioned by Dr. Indrani, it depends on the expertise of the surgeon performing the minimally invasive surgery. Also, if she has been counseled by for an open myomectomy by another surgeon, and you are competent enough to do it the minimally invasive route, well, you can go ahead with it. But remember, again, I'm saying, tell her that there is a chance of conversion from minimally invasive to open, and she can even land up in hysterectomy. So now we come to the lap myomectomy. The first hand-assisted lap hysterectomy has been documented way back 27 years by Pelosi and Pelosi for a 3 kg fibroid, which was occupying most of the abdominal cavity. They used a 10 millimeter laparoscopic incision and a 7.5 centimeters suprapubic incision, and hysterectomy was successfully performed in 150 minutes with a blood loss of 220 milliliters, and the patient was discharged on post-op day 2. It was in 1994, even before Pelosi and Pelosi, that NEDSA reported the technique of lap-assisted myomectomy, and I'm going to show you the video. So always remember that it is imperative to plan the approach of myomectomy based on the clinical situation as well as the surgical expertise to reduce the total operative time to 2 to 3 hours. Now, as far as lap myomectomy is concerned, it can be useful and it can be surgically performed for subserosal, intramural or type 2 submucosal fibroids. The advantages are it decreases the morbidity, shorter recovery time, better cosmetic results, less blood loss and fewer adnexal adhesions. But there is the disadvantage of a longer operative time. However, there is no difference in recurrence rate and pregnancy rate compared to the other surgical techniques. So the steps, always remember that incision is over the capsule after vasopressin infiltration. We have already mentioned it. We have mentioned it by the postgraduates. Dissection of capsule, removal of the myoma, multi-layer suturing. So now there is a place of laparoscopic assisted myomectomy. Whenever you have large fibroids which pose certain challenges during the minimally accessed myomectomy, as in limited visualization and there is a decreased space, with an increased incidence of conversion to an open procedure, there laparoscopic assisted surgery, it bridges the gap between open myomectomy and minimal access myomectomy because it's an excellent approach to tackle these large fibroids during myomectomy. It helps to quickly extract the fibroid by manual extraction, especially when malignancy is a concern. And one can do a multi-layer complete closure of the hysterotomy or the uterus without leaving any dead space because the dead space is a nidus for infection. And you can reconstruct the uterus. Suturing is also simple and easy. So patients with large fibroid occupying the entire pelvic cavity, they obstruct the surgical field and can be offered this approach. How does it help? It avoids a large midline vertical incision, thus reducing morbidity that is associated with the traditional open approach. It is best suited for difficult myomectomy of enlarged uterus that poses a significant risk of intraoperative conversion to laparotomy. Hospital stay is shorter, there is faster recovery, few adhesions, less blood loss, and better cosmetic results. Also, if you have mastered it, then it is a feasible and quick method with cold knife morcellation being achieved swiftly and safely. So this is a video of a large fibroid which was done laparoscopically assisted open myomectomy. And you can see how big it is in this image. Now, preoperative mapping to decide whether lap-assisted myomectomy technique should be carried out in a particular case or not. Initially, you do a survey. An MRI for mapping of the fibroids is very important. This is what I'm going to show in this case. Remember that after anesthesia, patient is in low lithotomy position with Foley's inserted, uterine manipulator in place in the uterine cavity. There's a 10 millimeter primary port placed in the midline, 8 to 10 centimeters above the upper border of uterus. On surface anatomy, if you see, it is 1 palm breadth above the upper part of uterus, which is sufficient to plan the laparoscopic port for telescope. And when pneumoperitoneum is achieved, this distance becomes 10 centimeters or more. Next, 2 5 mm ports are inserted on the left side of the patient and lower left port is placed almost at the level of the fundus. So an initial survey is done. You can see that because of the myoma, there is distortion of the anatomy. So first is to survey the abdominal cavity. You start from the left adnexa, that is the left tube and ovary, and then walk through from one round ligament to the other. You can see the instruments very gently pressing on the fibroid and reaching the other side, that is the right round ligament, to visualize the right tube and ovary. This is a huge fibroid which has been seen in the image that I have shown. Now, the right adnexa, you can see beautifully, and then the uterine body is anteriorly. The next step is to insert vasopressin in 1:10 dilution. Whenever you are injecting vasopressin, remember to inform the anesthetist that you are injecting it. And the other thing is always aspirate. Blood should never be aspirated. So now, having had a look, a transverse incision is given, followed by a cruciate hysterotomy incision on the uterus using these retractors to retract the abdominal wall. Small S-shaped curved retractors are used. This is followed by coring out the fibroid. So in situ fibroid coring is done. Myoma screw can be applied because we need traction and counter traction. So that huge fibroid is now being cored out. And once the bulk of the uterus, the bulk of the fibroid is reduced, then we can, take out the uterus from the abdominal cavity. This is cold knife morcellation being done using scalpel blade number 11. You can see that instead of doing a morcellation, in-bag morcellation, even this is a good technique. Now, once the bulk of the uterus is dealt with, we now take out the uterus. The bulk of the fibroid is dealt with. We now take out the uterus, look at the tubes and ovaries on both the sides, and multilayer closure of the uterine defect is begun, obliterating the dead space. So either you can use Vicryl, but now most of us have moved to barb sutures. So with this, we use the baseball technique, serosal layer, by inverting the raw edges, that is inside out, inside out. You can see that the surgeon is proceeding with these baseball sutures, and complete hemostasis has to be achieved. Initially, of course, like when you're in your learning phase, you can place a drain. However, with the experience, you don't require it. So the suprapubic incision is now closed. So imagine that huge fibroid coming out through this small incision. Now, this is another video that I have. In this, we did a laparotomy myomectomy, wherein this huge fibroid, I'll just run through it. You can see this is the MRI image. We always do a MRI before, whenever we want to plan our surgery, and this is being removed. The incision has been given anteriorly. This is a degenerated fibroid. So you need good assistance. Blood has to be kept handy. And again, this fibroid being cored. So as I said, this was a degenerated fibroid. Now, after the cold knife morcellation is done, then again, the uterus is that you don't damage the tubes and ovaries, because these are infertile patients. And if fibroid was the cause of infertility and the tubes are patent, then they can, conceive in the next few months. Although after myomectomy, we generally give them a time of 3 to 6 months before they attempt pregnancy or before they attempt conception. So now again, inside out, the barb sutures are being used to close the defect. And finally, this is the result that you get. Okay. Always remember, whenever you do a myomectomy or a hysterectomy for these patients, always send it for histopathological examination, because there is always a remote chance of maybe less than 1% of leiomyosarcoma. But if at all, leiomyosarcoma comes, then the patient has to be counseled accordingly. Next, we move on to robotics. And why robotics? So it has a better reproductive outcome and higher pregnancy rate. There is gentle tissue dissection and handling. 3D image with almost 10 times magnification of the operative field is provided by the surgical console. There is ease of suturing, improved and precise suture handling, and the ability of the robotic endoscopic instruments to mimic the dexterity of the human hand. So there is 7 degrees of freedom, which provides a great range of motion. There is depth perception to increase surgical precision. However, haptic feedback is lacking. It's there in the new version of the Da Vinci, that is DV5. Motion scaling with eliminate tremors. There is autonomous control over both camera and the instruments, which decreases surgical fatigue, improved cosmetic results, and improved post-operative pain outcomes. When we compare robotic versus laparoscopy, laparoscopic myomectomy is technically more demanding, but robotic definitely is better in terms of lesser intraoperative bleeding, number of blood transfusion required is less, postoperative complications are fewer conversions to open, and even shorter length of hospital stay. However, having said that, laparoscopic surgeons who have mastered myomectomy, with them, laparoscopy and robotic, it is comparable. So if we talk about the stepwise technique of robotic myomectomy, anesthesia given, it's a low dorsal lithotomy position, bladders catheterized. Always remember to catheterize the bladder, lest the veries, it goes straight into the bladder and you aspirate urine. So uterine manipulator is in place, pneumoperitoneum achieved, and the critical steps is the port placement, which is individualized to the patient's pathology and the abdominal topography. It is governed by the surgical history. As I said, depends on the surgical expertise of the surgeon. Always remember, do a clinical examination before you put the patient on the table. Have a dialogue with the patient and the relatives. The counseling session must be prim and proper. Your consent must be in place in the time of litigation. So clinical examination of the leiomyoma, a preoperative imaging, preferably MRI for careful surgical planning, and of course, the surgeon's preference to optimize access. So the stepwise technique, first port, remember, is the midline umbilical or supraumbilical port, wherein the camera goes in. Once the camera is in place, the uterine fibroids are visualized. Then the camera port also in Da Vinci Xi is 8 mm, and even the lateral ports are 8 mm trocars, which are inserted parallel to the midline. So generally what I do is that the ports are in a straight line, 8 to 10 centimeters apart. The assistant port, generally what we can take it either above the instruments, or we can take it around 2 centimeters above the anterior superior iliac spine. The assistant port helps in passing the instrument, suctioning, stabilizing, and for passing the suture material. Advanced smoke extraction systems can also be used, allowing the surgeon to work with constant lower intra-abdominal pressure, that is less than 10 millimeters of mercury, without compromising the exposure of the operating field. Remember, always have a look at the ureters bilaterally. You look for the major vasculature, the bowel, bladder, always should be away from your surgical field lest you injure it. So this is a posterior wall fibroid wherein vasopressin is being instilled to minimize the blood loss and for better visualization of the dissection planes. 20 units of vasopressin in 200 ml normal saline, ensuring that the tip is not aspirating blood and informing the anesthetist. I am repeating these two things again. Other options for synergizing ways of decreasing blood loss include either you can use intravenous tranexamic acid, oxytocin, misoprostol per rectally, or uterine artery ligation can also be done, or preoperative embolization if the facility is available and you have the IR. So once hemostasis is achieved, it is important to dissect out the fibroid by first incising the serosa and myometrium to the level of the pseudocapsule. A vertical incision is what is generally preferred, but you can even give it transversely or obliquely depending upon your preference. And this allows the surgeon to ergonomically close the hysterotomy. One can use the fourth arm, that is the robotic tenaculum, which will give static and consistent tension and helps to dissect and retract for oneself. Alternatively, this can also be provided with a bedside assistant using either a standard laparoscopic tenaculum or a myoma screw. So as I said, that the incision is given and further deepened to define the myoma tissue and the avascular plane. So always keep in mind that the ovaries, the uterine vessels, the fallopian tube, they should not get damaged. So be a careful surgeon. Dissect in the plane to allow the leiomyoma to be circumferentially enucleated and dissected from its fibrous attachment. And once the fibroid has been enucleated, you can put it in a bag in case you have to do a cold knife morcellation. And some people also use a string if there are a lot of fibroids. So instead of putting them in a bag, they just string the fibroids and then one by one they remove it later. So closure is similar to the traditional open technique. the same surgical principles apply. So remember, whenever as a postgraduate, you have to move step by step. So master open, then go on to the minimally invasive. Because the surgical principles, they remain the same. The hysterotomy is sutured from inside out in a 2 or 3 layered closure. In case the endometrium has been breached, the methylene blue can be injected directly into the uterine manipulator. And if there is a defect in the endometrium, that is, if it is being breached, then you will see the methylene blue coming out. You can even keep a Foley's inside, and the Foley's will be seen peeping out. So that endometrium breach can be closed with 3O absorbable suture. Swift closure is done with sparing use of diathermy, because that will cause myometrial necrosis and will be a site for future uterine rupture as and when she conceives. Now, the uterine incision, it is closed either with absorbable in either continuous or interrupted manner. Mostly people are moving towards barbed suture because it allows shorter operating time and lower blood loss, eliminates the need for surgical knots and reduces postoperative morbidity. So in robotic, when we do suturing, the number of layers sutured are generally more than laparoscopic surgery, resulting in better reconstruction of the uterus and consequently in better obstetric outcomes. Serosa largely approximated so that the closure is without any tension and hemostasis. So for in-bag morcellation, keep in mind the FDA 2014 warning. And there was a case in the US because of the patient had actually a leiomyosarcoma, which had both site metastasis, and it got pretty ugly. So if morcellation is avoided, enlarge the trocar incision or perform mini laparotomy, as I've already shown in the video previously, to remove the myomas. Another is the excite technique, where specimen retrieval and containment can be done. Self-retaining retractors can be placed, creation of C incision, tissue extraction, and facial closure. So this is a robotic myomectomy that we performed on a 37-year-old patient who had heavy menstrual bleeding and dysmenorrhea. There was a large intramural fibroid, 6 into 6 into 6 centimeters, and posterior myometrium. And there was hydrosalpinx on both the sides. So we went ahead and saw this fibroid. Upper abdomen should always be examined because in this case, there was Fitzhugh-Curtis syndrome. There were violent strings. Now, once adhesiolisis was done, you can see the hydrosalpinges on both sides. Adhesiolisis is being performed. Vasopressin is being injected, 20 units in 200 ml normal saline. This was followed by incising the serosa and the myometrium up to the level of the pseudocapsule, and the incision was given directly over the fibroid and carried deep till the myoma tissue and avascular plane was reached. So generally, when you are doing a myomectomy, you require traction and counter traction. And the assistant definitely has a role to play in the surgery, although in robotics, the camera and the instruments, everything is in the hands of the surgeon. You can see that fenestrated bipolar is in the left hand, and monopolar scissors, or the hot shears as we generally call them, is on the right hand. The myoma is grasped with a myoma screw and tracked with in the right port. It is fixed, the fibroid is fixed, and now with traction and counter traction, the fibroid will be removed from its bed. By blunt and sharp dissection, you can see that the fibroid is being enucleated. Since we used vasopressin, the blood loss is minimal. Now, once the fibroid is being removed, we do a closure of the myometrium using barbed sutures, as you can see in this, in 2 or 3 layers. So from the loop, the needle is being taken out. The barbed, it gives good approximation. However, it is expensive. So now the suturing is being done. The endometrium was not breached in this case. And the fibroid, we put it in a bag and removed it by giving a small incision, by giving a mini lap incision. I'm bringing it out, and then so finally the Surgicel is placed, and with a small incision, the specimen can be spirally cut. Ribbon coring technique using cold knife is done, and the specimen is sent for histopathology. So if we compare myomectomy across the eras, then as far as the incision is concerned, in open, there's a large laparotomy incision. However, in laparoscopy and robotic, there are small ports, around 3 to 4, through which the entire surgery is performed. Visualization, open, of course, it's direct visualization. In laparoscopic and robotic, it's 2D, 3D high definition in laparoscopy, and in robotic, it is 3D high definition with a 10x magnification. As far as dexterity is concerned, in laparoscopic, it is limited. In open laparotomy, of course, you're using your hands to perform the surgery. And in robotic, it is the surgeon sitting between the patient. It is like a computer interface between the patient and the surgeon. So there are wristed movements, 7 degrees of freedom, and tremor filtration is done. Blood loss is highest in open laparotomy as compared to laparoscopic and robotic. Suturing definitely in open laparotomy is easy. In laparoscopic, it is technically demanding. In robotic, it is precise and ergonomic. Hospital stay is shorter with the minimally invasive approach. Recovery is faster with the minimally invasive approach. And complex fibroids, open is definitely suitable. In laparoscopic, depends on the expertise of the surgeon. And robotic is excellent for complex cases. As far as cosmesis is concerned, well, minimal scars in the minimally invasive route. And the overall advantage is that open, it is a well-established and cost-effective procedure. In laparoscopy, it is minimally invasive with faster recovery. And the robotic, there is precision surgery with superior outcome and faster recovery. So the take-home message is that we have moved from the era of open to laparoscopic to robotic. However, each surgery has its own place depending on the patient and the surgeon. From larger incisions, we now are into the era of precision surgery with enhanced visualization, dexterity, faster recovery, and improved patient outcome. So there was this systematic review on robotic assisted laparoscopic versus abdominal and lap myomectomy, and it was published in International Journal of Obs and Gynae in 2024. They had a total of 32 studies with 6,357 patients, of which almost 2,000 women underwent robotic assisted laparoscopic myomectomy, and the operating time was significantly longer, and the incidence of cesarean section after myomectomy was significantly lower in robotic laparoscopic myomectomy than in laparoscopic myomectomy. So they compared the operation time, blood loss, blood transfusion rate, complication rate, total cost, length of hospital stay, and pregnancy rate of patients with robotic and the other two. So they concluded that the safety and effectiveness of robotic is definitely superior to that of abdominal myomectomy, but inferior to those of laparoscopic myomectomy. However, most of the studies included were observational studies, so there was a selection bias. And even amongst the statistics, they said that the surgeons did not mention the confidence interval, etc. So again, with this, of course, this is what the evidence says, but it depends upon the surgeon's expertise and the availability of whether you have the laparoscopic sets, of course, are available everywhere. And whether you have access to the robotic system or not, that depends on where you are practicing. So thank you for having me. And this is where Bhagirathi and Alaknanda meet in Devprayag to form the Ganga. So hope to see you soon in our Devbhumi, that is Uttarakhand. Thank you so much, sir, for giving me this opportunity.
Thank you so much, Dr. Anupama. I think it was an excellent presentation, and you have done a very fantastic job for across the eras showing. I am very much sure the students has got the glimpse from where to here and what is holding in future. So that is really is very wonderful and nice presentation. So
Thank
much.
you, sir.
Any comments from any of the faculties or anyone?
Anupma ma'am, as usual, excellent. We really enjoyed from basics open to what was in our era open and now to robotics. Thank you so much, ma'am.
Yeah.
Thank you.
Thank you so much.
Thank you.
Ma'am, your videos were excellent.
Thank you.
Yeah,
Thank you
the
so much.
demonstration and everything were really brilliant, Dr. Anupama. And you have justified the topic, and I entrusted on you, and more than that, what I expected. So thank you so much for this wonderful talk. And for the students, you would like to say this: all the presentations, all the recordings of the class are available in ICG website, as well as in the YouTube. So almost in the last, all the topics and everything are available in the YouTube as well. So thank you so much, Dr. Anupama, for your wonderful presentation again. And we'll move on to the last session, that is on the exciting one for the students who are waiting for the quiz, because leiomyoma is such a common topic, and I'm sure it will be very much an important and insightful quiz for the students they can reflect on. And now for this, I would like to request Dr. Archana and their team, Dr. Nazia, Dr. Apala. Over to you, Dr. Nazia.
Thank you, Hafizur sir. And thank you all the organizers, and especially Bhaskar sir, Sheila ma'am, Dr. Ashish Kumar, Dr. Sadhna ma'am, Suvarna ma'am, and Prateek sir. And a very I am very grateful that you all invite us to conduct that quiz, especially Ashish sir and Hafizur sir. Thank you very much. And this is an opportunity to conduct this quiz. Now we are proceeding to the quiz, and which is the topic is same, fibroid leiomyoma. And I have shared already. So if my screen is visible, please tell me.
Yes, Dr. Nazia, it's visible.
Okay. So I am just making the host live, and after this we will get the quiz QR code as well as the code. So all of the PGs who have joined, they can just a minute. Give me some time. So I'm now loading the game pin. So the game pin is visible on the screen. It is 145356, or I am enlarging the QR code. So either by game pin or by the QR code, all the PGs, please join. All the instructions are already given, that it is a Kahoot quiz. You must have Kahoot app installed, and you can join the quiz by the pin as well as the QR code. I think many of them are joining. So Pranavi, Sabyashi, Pooja, Nirosha, Rohit, Sonali, Abarna, Shweta. It is a request that don't join with a nickname. Join with your full name, please. That PK, GR, AK, Dr. M, please join with your full name. It is very difficult to identify who is joining, so please join with your full name. SPPKSGAK, please join with your full name. Who is that Kittu? So up to now, I think 25, 26, 27. The number is increasing. Please join with your full name. Who is then? Then SPAK. It is my request. Please join with your name. So we are waiting for all to join. 31 have already joined. 32, 33. Actually, we are short of time, so please join quickly. Or if anyone is having problem in joining, you can. "34 students have joined. 35. Hafizu sir, Ashish sir, up to what time we should wait for them to join? And if you allow me, then I will start. गेम खेल लोगे? 37 students, 38. Number is still increasing. Back up all the PGs. Please join quickly. Next minute, we are starting the quiz. Ashish sir, Sheila ma'am, Hafiz sir, shall we start? Okay. So now we are starting this Kahoot quiz. Please ensure that you have a stable network. Otherwise, if you are out, then you will miss the questions. And it is difficult in Kahoot to cover. So let's start. Now I'm starting the quiz. Ready? So in the first part, I am handing over to Dr. Apala. Initially,
Thank you, ma'am. And a very warm good afternoon to respected seniors and dear friends. And lots of best wishes to all the participants. And now we'll be starting the quiz. Which extracellular matrix component contributes most significantly to increased stiffness and volume of leiomyoma? Is it elastin, collagen types 1 and 2, laminin, or keratin? So the correct answer is collagen types 1 and 2, and the majority of you have got it right. Congratulations. Coming to the next question. So we have Rishi scoring the topmost for the first question. Fastest finger first. A 38-year-old woman with multiple intramural fibroids, most frequently identified mutation in sporadic uterine leiomyoma. Is it P53, KH mutation, MED12 or HMG-A2. Most frequently identified mutation in sporadic uterine leiomyoma. The correct answer is MED12. So 10 of you got the right answer.
AH mutation is in fibroids which are associated with renal cell carcinoma. And TP53, you all know, in advanced ovarian cancer.
Ovarian cancer. Dr. M coming to the top notch, and you don't have your full name. Which factor is associated with a decreased risk of developing uterine leiomyoma? African ancestry, obesity, early menarche, or multiparity? Decreased risk of developing a leiomyoma. So the correct answer is multiparity. Rest all are associated with an increased risk. Dr. M again remaining at the top first position, followed by Satvika and SNK. The most common degeneration occurring during pregnancy, a very easy one: hyaline degeneration, myxoid degeneration, carneous degeneration, or a cystic degeneration. The most common degeneration during pregnancy. So the correct answer is carneous degeneration, which is another name for red degeneration only.
Okay, that's why they were confused. Red or carneous degeneration is most common during pregnancy. Scoreboard.
Satvika jumping up to the top, followed by Nirosha and SNK again. Which histological finding is characteristic of hyaline degeneration? Increased mitotic figures, collagen deposition replacing smooth muscle, nuclear atypia, or coagulative tumor necrosis? Hyaline degeneration. So the correct answer is collagen deposition replacing smooth muscles. We have SNK coming to the top now, followed by Pooja and Satvika. Which growth factors plays the greatest role in extracellular matrix accumulation and fibrosis within uterine leiomyoma? Growth factor this time. So is it the transforming growth factor beta, the platelet-derived growth factor, the epidermal growth factor, or the fibroblast growth factor? So the correct answer for this one is transforming growth factor beta. This is responsible for extracellular matrix accumulation in fibrosis with uterine leiomyoma. Pooja climbing to the first position now, followed by Dr. M and Nirosha. Pseudocapsule surrounding a uterine fibroid is primarily composed of compressed endometrial glands, compressed myometrium containing neurovascular bundles, overlaying peritoneum, or dense collagen without vascularity. The pseudocapsule of the fibroid. The correct answer is compressed myometrium containing neurovascular bundles. So congratulations again, 18 of you have got it right. Dr. Ronit is climbed to the second position. Pooja again retaining the top position. FIGO type 2 fibroid is defined as pedunculated intracavitary, less than 50% intramural with subserosal component, more than or equal to 50% intramural with submucosal component, or completely intramural. FIGO type 2. So the correct answer is more than or equal to 50% intramural with a submucosal component. This was an easy one. All of you should have got it right. So Pooja again maintaining the top position, followed by Nirosha and Meena. On MRI, which characteristic strongly suggests leiomyosarcoma rather than a benign leiomyoma? So is it well-defined margins, a homogeneous low T2 signal, irregular borders with a central necrosis, or calcification? MRI finding of leiomyosarcoma. So the correct answer here is irregular borders and also having a central necrosis along with it. Pooja, first position, followed by Meena Pichai and SNK. Which feature best differentiates adenomyosis from fibroids on an MRI? So is it low T2 signal, a pseudocapsule, calcification, or a thickened junctional zone more than 12 millimeter? Differentiating feature of adenomyosis with a fibroid on MRI. So the correct answer is thickened junctional zone, which should be more than 12 millimeter. Again, Pooja, followed by Meena and SNK. Which imaging feature on color Doppler ultrasound is most characteristic of a benign uterine leiomyoma? Is it complete absence of vascularity, a chaotic central vascularity, high resistance flow confined to endometrium, or a peripheral circumferential vascular pattern? Most characteristic of a benign uterine leiomyoma. So the correct answer is a peripheral circumferential vascular system, a vascular pattern. You keep doing these ultrasounds so often, and therefore 30 of you have got it right this time. Again, Pooja is the leader. Which medication directly blocks progesterone receptors and significantly reduces the fibroid volume? Is it leuprolide, mifepristone, tranexamic acid, or letrozole? Reducing fibroid volume by blocking progesterone receptors. The correct answer is mifepristone. So who's the fastest finger this time? Pooja again on the top with SNK climbing up to the second position. Following GnRH agonist therapy, uterine volume typically decreases by approximately what percent? Is it 10 to 20%, 20 to 30%, 35 to 60%, or 70 to 80%? Following GnRH agonist therapy, how much uterine volume do you expect to decrease? So the correct answer is 35 to 60%. SNK coming to the top position, followed by Meena and Pooja. During a laparoscopic myomectomy, excessive vasopressin infiltration may cause which of the following side effects? Is it hyperglycemia? Is it bradycardia with hypertension, pulmonary fibrosis, or hyperthermia? Excessive vasopressin infiltration. Yes, the correct answer is bradycardia and hypertension, and all of you have got it right because we do keep facing it in OT every now and then. So the top scorer is SNK, followed by Meena and Pooja. 34-year infertile woman has a 3 centimeter intramural fibroid with no distortion of the endometrial cavity. Which is the most appropriate management? Is it expectant management, hysteroscopic myomectomy, laparoscopic myomectomy, or uterine artery embolization? An intramural 3 centimeter fibroid. So the correct answer is expectant management. However, had this fibroid been a submucosal one, a hysteroscopic myomectomy would be the preferred option. So majority of you have got it right.
Hello.
So now I would like to hand over to respected Dr. Nazia Ishrat ma'am for the next set of questions. Over to you, ma'am.
Thank you, Apala. So we now proceed to more questions. All the PGs ready? Your next question is regarding hormonal dependence of uterine fibroids. What is the role of estrogen? Is it degradation of extracellular matrix, induction of progesterone receptors, inhibition of P13K pathways, or direct apoptosis of myometrial cells? It is induction of progesterone receptor. Estrogen is working to induce progesterone receptors. So there is both role of estrogen and progesterone in causing fibroids. So now the scoreboard, SNK is still on top. Next. According to FIGO, what number is assigned to the red fibroid in this picture? All the fibroids are white, yellow, but one red fibroid. It is numbered as 2, 3, 4, or 5, according to FIGO classification. Correct. It is 2, more than 50% in the intramural and with submucous component, which was the previous question. It is type 2 fibroid according to FIGO classification. Score card, same except Rohit is climbing at 4th position. How does the response to progesterone differ between endometriosis and uterine fibroid? You all know progesterone plays a role in endometriosis as well as in fibroid, but the response is resistance versus growth, growth versus apoptosis, hypersensitivity versus resistance, or inhibition versus stability. Correct answer is resistance versus growth. There is resistance of growth in endometriosis while growth occurs in fibroid due to progesterone stimulation. Now the scorecard, Pooja is climbing on 1st position followed by SNK and Meena. Next, which classification provides diagnostic information for planning complex hysteroscopic resection of submucous fibroid? Usually we deal submucous fibroid by hysteroscopy. So classification is palm point, Musa classification, Lasmer classification, or FIGO classification. Correct answer is Lasmer. Yeah, straw classification. Straw is Lasmer, provide everything about the submucous fibroid, site, size, depth of penetration, everything. While Musa is morphologically ultrasound classification. Okay. So now this is the scoreboard, same as, but Shweta is on 4th position now. True and false broad ligament fibroids are differentiated by which anatomical position? Anatomical position of which of this structure? Ureter, uterine artery, external iliac artery, or internal iliac artery? Correct answer, and most of you have got it right. Ureter. By ureter, we can delineate whether it is a true broad ligament fibroid arising from broad ligament or false, which is arising from uterus and growing into the broad ligament. So Pooja is still on the top. Next. Ulipristal acetate used in the treatment of fibroids fall in which category of drug? Is it a estrogen, anti-estrogen, selective estrogen receptor modulator, or selective progesterone receptor modulator? Ulipristal acetate or Elata? So most of you got it right. It is selective progesterone receptor modulator. And now the scoreboard, I think it is the same. Next question. New oral GnRH antagonist like
elagolix are combined with ADVEC therapy. The purpose of this combination is enhancing fibroid volume reduction, increasing patient fertility rate, mitigating bone density loss, or preventing serious liver toxicity. This addition is for the purpose of, most of you got it right, to mitigate the bone density loss, which is the major complication of this therapy. Now the scoreboard. Same Pooja, SNK, followed by Meena, Shweta, and Rohit. Which instrument is used for hysteroscopic myomectomy? Alligator forceps, hysteroscopic scissor, Maryland forceps, or resectoscope? Main instrument is resectoscope. You should know the name of all the instruments we use in laparoscopy and hysteroscopy. Now SNK is climbing to top. Methods to control intraoperative blood loss during an abdominal myomectomy include all except preoperative treatment with progesterone, local injection of vasoconstrictive agent, controlled induced hypotension, or use of a uterine tourniquet. In myomectomy, every attempt is made to decrease the blood loss, which is not. Pre-operative treatment with progesterone is not a method to decrease the blood loss. Correct. So, scoreboard, same scoreboard is ticked. Now, what is the reported recurrence rate of fibroids 3 years after the abdominal myomectomy? 10%, 25%, 40%, or 60%. We all know when we are going for myomectomy, we counsel about recurrence. So what percentage of recurrence occur in 3 years? Correct answer is 25%. In 25% cases, there is recurrence of fibroid because of its etiology. Now, SNK, Pooja, Meena, Shweta, and Rohit, these all 5 are retaining their positions. What is the significant limitation of LNG intrauterine system in the management of uterine fibroid? Induction of premature menopause, decreased risk of device expulsion, increased risk of liver injury, or lack of volume reduction. When we use LNG IUS in fibroid management, what is the limitation? So it doesn't decrease the volume of fibroid. Other drugs like mifepristone, GnRH, they decrease the fibroid volume, but LNG is relieving symptom, not the volume. So now the scoreboard, now Meena is climbed to second position, SNK on top, Pooja on third. Next, name the mass and the star structure. In ultrasound, 2 things are visible. One is the mass and other is structure with a black star. You have to name them. Ovarian malignancy and uterus, broad ligament, fibroid and uterus, ovarian cyst and uterus, or ovarian mass or hydrosalpinx. Correct answer, most of you got it right. Broad ligament fibroid and the uterus is visible in the ultrasound picture. So now scoreboard, now Pooja is on the second and Shweta on the third. Next question. Few questions are left. You have to name this suture. This is used in myomectomy. Is it baseball suture, barb suture, Nausicaa suture, or near stitch? It is baseball suture. In the lecture of Anupama ma'am, she also named this suture and she used to finally reconstruct the uterus. This baseball suture. The scoreboard is the same. Few questions are left. Name this film. It is used to prevent adhesions after myomectomy. Every attempt is made to prevent adhesion formation. This film, is it a suprafilm or polypropylene mesh, composite mesh, or biological mesh? which is used to prevent the adhesion formation during myomectomy? Correct answer is suprafilm. It is also called interseed, which is kept on the surgical site so that adhesion will not form. So scoreboard, the same scoreboard, SNK, Pooja, Shweta, Meena, and Rohit. I think this is the last question. Following procedure is planned for a patient with fibroid. Which statement is false regarding this procedure? You can see in the image, the procedure is shown. It can be done in nulliparous. Ovarian failure is common complication. PVA particles are used. And this is, I think, under radiological guidance. So this cannot be done in nulliparous women because this procedure is uterine artery embolization and the fertility is somehow compromised. That's why it is not done in nulliparous women. But it is a method of managing fibroids. So I think this is final scoreboard, the podium. Meena Pichai, she is on the 3rd position. Congratulations, Meena. Pooja is on the 2nd position. And the winner of FOGSI ICOG PG quiz is SNK, but we don't know the name. Shweta and Rohit are on the 4th and 5th position. So congratulations to all the winners and all the participants for attending this quiz. Quizzing is always very good method of learning, and we learn a lot with quiz also. So SNK, SNK, who is SNK? Please unmute and answer. Hafiz sir?
Dr. Nazia, probably SNK will be on the other side, participant side. Okay. And those are in the participants, they can't have the interaction, they can only listen. So if they can put in the chat box SNK.
So sir, please take a snap of the podium.
Geeta, is there any way to find it out?
Yes, sir.
How do we find out who is SNK? Because he or she would not be able to speak up.
Hello.
If it is on the... Yes, I can listen you.
Okay, sir, we will share in the group.
Okay, you will share in the group.
Also, I want to know their affiliation, from which medical college, which year of residency they are. SNK, Pooja, Meena Pichai, Rohit, and Shweta. Please put it in the chat box so that we can know the winners.
Yes. So SNK, Pooja, and Meena, if you can put in the chat box. So because your contact information is also required for sending your awards from the ICOG office. So please put up your details in the chat box so that the team can get your details.
I'm stop sharing.
Yes. I think thank you, Dr. Nazia, so much, and Dr. Apala for conducting a wonderful quiz. And all of you have been there, especially along with Dr. Archana Madam, for consistently doing the program from the last few months since we have added quiz, I think from the last year, from 2025. Thank you so much.
I think it is 1.5 years taking quizzes of FOGSI ICOG.
So the program is going on from 2021. So the program is for, it is completed 5th year and running the 6th year. So, yes. So Dr. Ashisa, you are there? So thank you so much. We'd like to have, we have come to the end of this month, July month's ICOG PG clinic. I would like to thank you, our President, Dr. Bhaskar Paul, Chairperson of ICOG, Dr. Sheila Mane, Chairperson-elect Dr. Ashok Kumar, then Vice Chairperson Dr. Sadhna Gupta, FOGSI Secretary General Dr. Suvarna Khadilkar, ICOG Secretary Dr. Pratik Tambe, and our consisting Ashish Mukhopadhyay sir for having been there all throughout for this program. So for this today's session, my sincere thankful for Dr. Nikhil Shetty for conducting a wonderful demonstration of occipital posterior position. I am sure the students will be really benefited for this program. Then I must thank Dr. Vijaya, Madam is Professor and Head of ESIC Medical College, for the students, Dr. Divya Shankar and Dr. Dhanishya, for having a wonderful presentation, and I'm sure this is going to them lots of opportunity as well as the confidence for future presentations. And I constantly get requests from different students, and then we discuss in the ICOG office and allow them which college or which to be given the presentation. We consistently moving the college from each different college, the different zones. So I'd like to thank you, Madam, and the students, Dr. Divya and Dr. Dhanishya. Then all the faculties, including Dr. and Dr. Meeta Gupta, Dr. Indrani Roy, Dr. Sangha, and Dr. Harikaru for all of your valuable contribution for the benefit of the students. Then I'd like to specially thank Dr. Anupama Bahadur for taking her time and giving such a glimpse and good presentation along with the good videos for the students. There is myomectomy across the eras, comparative between open, laparoscopic, and robotic myomectomy. So thank you so much, Dr. Anupama Bahadur. And the last but not the least, that is on the quiz, which has also been consistent in the schedule from the last 1.5 years. So I'd like to thank Dr. Archana Kumari, Madam, and along with their team, Dr. Nazia and Dr. Apala. So thank you so much, everyone.
Thank you, sir.
Yeah.
Thank you, Apala, for being my side. Thank you,
So Yogita,
students.
you can stop recording, and thank you so much.
Thank you, sir. Okay. Bye.
Thank you so much, everyone, for joining today's
Thank
session.
you, Dr. Hafizu,
Yeah,
for the
thank you.
opportunity. Thank you so much. I enjoyed it.
Yeah, I know. I was seeing Dr. Niharika. Thank you so much for giving your valuable time on Sunday. And the team of the Aristo, Mr. Ramnath, and everyone, thank you so much for your support.
So from here, I'm ending this meeting. Thank you.
Yeah, sure. Thank you so much. Bye-bye. Have a good day.